Hypothyroidism in a 12-year-old girl can manifest with various symptoms, reflecting the deficiency in thyroid hormone, which is crucial for growth, development, and metabolism. The clinical presentation can include A. Characteristic symptoms and pathophysiology. Fatigue and weakness, due to decreased metabolic rate. Weight gain, despite poor appetite caused by reduced energy expenditure. Growth retardation. Delayed puberty and slowed growth due to inadequate thyroid hormone levels affecting growth hormone synthesis and skeletal maturation. Cold intolerance, due to decreased basal metabolic rate and reduced heat production. Constipation, reduced gut motility as a result of decreased metabolic rate. B. Clinical presentation and diagnosis, bradycardia, lower heart rate than expected for age. Dry skin and hair, changes in skin texture and hair quality, including hair loss. Delayed puberty, menstrual irregularities, or delayed onset of menstruation. Goiter, enlargement of the thyroid gland, detectable on physical examination, indicative of the gland's effort to produce more thyroid hormone. Mental health changes, including depression, decreased concentration, and poor school performance. Diagnostic tests. TSH, thyroid stimulating hormone test, elevated levels indicative of primary hypothyroidism. Free T4, decreased levels confirm the diagnosis. Thyroid peroxidase antibodies, TPO, to assess for autoimmune thyroiditis, Hashimoto's, a common cause in this age group. Thyroid ultrasound, useful if goiter is present to assess thyroid gland morphology. C treatment. Levothyroxine, synthetic T4 adjusted based on weight and TSH levels, is the standard treatment. Regular monitoring. TSH and free T4 levels are monitored to ensure adequate dosing. D prognosis. Good with treatment. Symptoms improve with appropriate thyroid hormone replacement. Regular follow-up. Required to adjust medication dosage, especially during growth spurts and puberty. Differential diagnosis table. Condition distinguishing features. The appropriate hypothyroidism. Elevated TSH, low free T4, possibly goiter, depression, mood predominant, normal thyroid function tests, growth hormone deficiency, short stature, normal thyroid function tests, chronic illness, specific to the illness, normal thyroid function tests, eating disorders, weight loss, abnormal eating habits, normal thyroid function tests. High yield points. Hypothyroidism can significantly affect growth and development in children and requires early detection and treatment. The most common cause in children is autoimmune thyroiditis, Hashimoto's. Regular monitoring of thyroid function tests is essential in managing treatment effectively. Hypothyroidism in infants, often referred to as congenital hypothyroidism when present at birth, can have serious consequences if not detected and treated early. The condition can lead to impaired growth and developmental delays. Here are the key aspects of hypothyroidism in infants. A. Characteristic symptoms and pathophysiology. Prolonged jaundice, lasting more than 2 weeks post-birth. Feeding difficulties. Poor feeding, choking episodes. Constipation, persistent, which is unusual in infants. Hypotonia, decreased muscle tone appearing floppy. Large fontanelles, delayed closure of the skull's soft spots. Macroglossia, enlarged tongue which may interfere with feeding and breathing. Umbilical hernia, due to weakened abdominal muscles. Cold intolerance, feeling unusually cold to touch. B. Clinical presentation and diagnosis. Growth retardation, poor growth or failure to thrive. Developmental delays, delayed milestones such as holding up the head, sitting, or crawling. Bradycardia, unusually low heart rate for age. Skin changes, dry, mottled skin, and edema, particularly facial puffiness. Diagnostic tests, neonatal screening. Most countries have newborn screening programs that include TSH and T4 levels. TSH test. Elevated TSH is a primary indicator. Free T4 levels. Low levels confirm the diagnosis. Thyroid ultrasound or scintigraphy, to determine the presence, size, and location of thyroid tissue. C. Treatment. Levothyroxine. Immediate initiation of treatment with synthetic thyroid hormone is crucial to prevent intellectual disability and growth failure. Dose adjustments. Regular follow-ups for dose adjustments based on growth, TSH, and free T4 levels. D. Prognosis. Excellent with early treatment. Most infants diagnosed and treated early lead normal lives. Risk of neurodevelopmental delays. If treatment is delayed, there's a risk of intellectual disability and developmental issues. Differential diagnosis table, condition distinguishing features. Congenital hypothyroidism, elevated TSH, low T4, possible presence of goiter. Down syndrome. Specific facial features. Developmental delays may also have thyroid dysfunction. Neonatal jaundice. Predominantly elevated bilirubin usually resolves without thyroid issues. Cystic fibrosis. Respiratory symptoms, failure to thrive, different etiology. High yield points. Early detection and treatment of hypothyroidism in infants are critical to prevent irreversible intellectual disability and physical growth issues. Neonatal screening for hypothyroidism is an essential public health measure. Regular monitoring and dose adjustments of levothyroxine are necessary to ensure optimal development and growth in infants with hypothyroidism.
Hyperthyroidism in a 15-year-old girl typically manifests through symptoms that reflect an increased metabolic rate due to excessive thyroid hormone levels. Here are the detailed aspects of hyperthyroidism in this demographic. A. Characteristic symptoms and pathophysiology. Weight loss, despite increased appetite and food intake due to accelerated metabolism, increased heart rate, tachycardia, can lead to palpitations and contribute to feelings of anxiety. Heat intolerance, feeling excessively hot and sweating more than usual. Fatigue and muscle weakness. Despite high energy levels, there's often a paradoxical feeling of tiredness and weakness. Tremor, fine shaking, particularly noticeable in the hands. Mood changes, including irritability, anxiety, and difficulty concentrating. B. Clinical presentation and diagnosis. Goiter, enlargement of the thyroid gland, which may be accompanied by a visible swelling at the base of the neck. Exophthalmos in Graves' disease, bulging eyes due to autoimmune inflammation behind the eye. Menstrual irregularities, such as light or missed periods. Accelerated growth, increased potentially leading to taller stature, but may also cause early closure of growth plates, limiting final height. Diagnostic tests. TSH test. Lower than normal levels indicate hyperthyroidism. Free T4 and free T3, elevated levels confirm the diagnosis. Thyroid stimulating immunoglobulin, TS test. High levels suggest Graves' disease, the most common cause of hyperthyroidism in this age group. Thyroid ultrasound, to assess the thyroid size and to look for nodules. C treatment, antithyroid medications, such as methimazole or propylthiouracil, to reduce thyroid hormone production. Beta blockers, to manage symptoms like tachycardia and tremors. Radioactive iodine therapy, in some cases to destroy overactive thyroid tissue. Thyroid surgery, rarely removal of the thyroid gland might be considered. D. Prognosis, generally good with treatment. Most symptoms can be controlled effectively with proper treatment. Monitoring required. Regular follow-up is essential to adjust treatment and monitor for potential complications. Differential diagnosis table, condition, distinguishing features. Hyperthyroidism, low TSH, high free T4, T3, goiter, exophthalmos in Graves' disease, anxiety disorder, normal thyroid function tests, symptoms of anxiety not accompanied by other signs of hyperthyroidism, anemia, fatigue, weakness, but with low hemoglobin, and normal thyroid function tests. Eating disorders, weight loss, menstrual irregularities, but associated with eating habits and normal thyroid function tests. High yield points. In adolescence, hyperthyroidism often presents with weight loss, increased appetite, heat intolerance, and menstrual irregularities. Graves' disease is the most common cause of hyperthyroidism in this age group and can present with exophthalmos. Early diagnosis and treatment are crucial to prevent complications such as osteoporosis and cardiovascular issues. Regular monitoring of thyroid function tests is essential during treatment to adjust medication doses and prevent both undertreatment and overtreatment. Congenital adrenal hyperplasia is a group of inherited disorders affecting the adrenal glands, which produce essential hormones such as cortisol, aldosterone, and androgens. In infants, the symptoms and presentation of CAH can vary based on the specific enzyme deficiency, with 21-hydroxylase deficiency being the most common form. Here's a detailed overview. A. Characteristic symptoms and pathophysiology. Salt wasting crisis. In severe cases, lack of aldosterone leads to dehydration, hyponatremia, low sodium, and hyperkalemia, high potassium, which can be life-threatening if not treated promptly. Virilization in females, ambiguous genitalia at birth due to excess androgen production. Males typically appear normal at birth. Poor feeding and weight loss due to adrenal insufficiency. Hypoglycemia, low blood sugar levels because of inadequate cortisol production. B. Clinical presentation and diagnosis. Dehydration and vomiting, symptoms of a salt wasting crisis, potentially leading to shock if untreated. Rapid heart rate and weak pulse, indicative of dehydration and electrolyte imbalances. Ambiguous genitalia in female infants. Enlarged clitoris and fused labia resembling scrotal sacs. Normal male genitalia. In male infants, the genitalia usually appear normal, but they may have enlarged penises. Diagnostic tests. Electrolyte levels, assessing for hyponatremia and hyperkalemia, 17-hydroxyprogesterone levels, significantly elevated in most forms of CAH. ACTH stimulation test, abnormal response helps confirm the diagnosis. Genetic testing to identify specific enzyme deficiencies and mutations. C. Treatment, glucocorticoid replacement, such as hydrocortisone to replace deficient cortisol and suppress excessive androgen production. Mineralocorticoid replacement, fludrocortisone for cases with aldosterone deficiency to manage salt wasting and maintain normal electrolyte levels. Sodium chloride supplements for infants with salt wasting CAH, particularly during the neonatal period and illnesses. Surgical correction. For females with virilized genitalia, reconstructive surgery might be considered to normalize the genital appearance. D. Prognosis. Good with early treatment. With proper hormonal replacement therapy and management, individuals with CAH can lead normal lives. Regular monitoring needed. Electrolyte levels, hormone levels, and growth parameters must be closely monitored, especially during growth spurts and illnesses. Differential diagnosis table, condition, distinguishing features, congenital adrenal hyperplasia, electrolyte imbalances, ambiguous genitalia in females, elevated 17-OHP, adrenal insufficiency, similar symptoms of dehydration and hypoglycemia, but without virilization or salt wasting crisis. Androgen insensitivity syndrome, normal male internal genital structures with female or ambiguous external genitalia, normal electrolytes. Polycystic ovary syndrome in adolescence, irregular periods, excess hair growth, but normal adrenal function and no electrolyte imbalances. High yield points. CAH due to 21-hydroxylase deficiency is the most common form, presenting with salt wasting, virilization in females, and potentially life-threatening adrenal crisis if untreated. Early diagnosis, typically through newborn screening programs, and prompt initiation of treatment are crucial to prevent complications and mortality. Lifelong management includes hormone replacement therapy and monitoring for potential complications such as adrenal crises during stress or illness. Acute bronchitis, an inflammation of the bronchial tubes in the lungs, primarily results from viral infections. Its symptoms can overlap with other respiratory conditions but are typically characterized by the following. A. Characteristic symptoms and pathophysiology. Cough, the hallmark symptom, which can be productive or non-productive and may persist for weeks. Mucosal inflammation, leads to increased mucus production, contributing to the cough and potential sputum production. B. Clinical presentation and diagnosis. Productive cough. Sputum may be clear, white, yellowish gray, or green in color. Rarely, it may contain streaks of blood. Wheezing may occur due to airway constriction. Shortness of breath, especially during physical activity. Fatigue, common due to the body's immune response and reduced oxygen exchange efficiency. Fever and chills, less common than in pneumonia. When present, fever is usually low grade. Chest discomfort. Patient may describe chest soreness due to coughing. Diagnostic approach. Diagnosis is primarily clinical, based on symptoms and physical examination. Chest X-ray may be performed to rule out pneumonia, especially if the patient presents with high fever, shortness of breath, or is of advanced age. Pulse oximetry, to check oxygen saturation levels if there's concern for decreased oxygenation. Sputum tests and cultures, rarely indicated but may be used if bacterial infection is suspected or to rule out conditions like pertussis, whooping cough. C treatment. Symptomatic relief includes rest, hydration, and the use of over-the-counter OTC cough remedies and pain relievers like ibuprofen or acetaminophen. Cough suppressants, such as dextromethorphan, may be used to reduce coughing bouts, but their use is controversial as coughing helps clear mucus from the bronchi. Expectorants, like guaifenesin, may help thin mucus, making it easier to cough up. Inhalers. A short course of a bronchodilator inhaler may be prescribed for wheezing. Antibiotics. Not typically recommended as most cases of acute bronchitis are viral. However, they may be considered in cases suspected to be bacterial in nature or in high-risk patients. D. Prognosis. Generally good. Symptoms usually improve within a few weeks, though the cough can persist for up to several weeks after other symptoms have resolved. Differential diagnosis table. Condition. Distinguishing features. Acute bronchitis. Productive cough, wheezing, usually no high fever. Pneumonia, high fever, shortness of breath, localized chest pain, often productive cough with purulent sputum. Asthma, episodic, associated with triggers, wheezing, responsive to bronchodilators. COPD, history of smoking or chronic exposure to lung irritants, progressive, associated with chronic cough and dyspnea. High yield points, the most common symptom of acute bronchitis is a persistent cough, which may last for several weeks. Acute bronchitis is predominantly viral, so antibiotics are generally not recommended unless there is strong suspicion of a bacterial infection. Symptomatic treatment and supportive care are key, with a focus on relieving the cough and ensuring adequate hydration. It is important to differentiate acute bronchitis from pneumonia, which requires a different treatment approach and has a more severe clinical presentation. Pharyngitis, or inflammation of the pharynx, can be caused by both viral and bacterial pathogens with distinct characteristics in their presentation. Understanding the differences is crucial for appropriate management. Viral pharyngitis, symptoms and pathophysiology, sore throat, often accompanied by other cold symptoms such as a runny nose, cough, and hoarseness. Conjunctivitis, red, itchy, watery eyes can accompany viral infections. Oral ulcers, small sores inside the mouth or on the lips, more common in viral infections like Coxsackie virus, hand, foot, and mouth disease. General malaise and fatigue, often present but not specific to viral infections. Bacterial pharyngitis, symptoms and pathophysiology, sore throat, typically more severe than in viral infections and may be accompanied by painful swallowing. Fever. Higher temperatures are more common and pronounced in bacterial pharyngitis, especially in cases caused by Streptococcus pyogenes, strep throat. Exudates, white or yellow patches or streaks on the tonsils or back of the throat. Anterior cervical lymphadenopathy, swollen, tender lymph nodes in the neck. No cough. The absence of a cough is a classic sign that may help differentiate bacterial from viral pharyngitis. Petechiae, tiny red spots on the roof of the mouth, are a hallmark of strep throat, but not always present. Diagnostic approach. Rapid antigen detection test, RAT for strep throat, used to quickly diagnose strep throat, with positive results indicating the need for antibiotic treatment. Throat culture, considered the gold standard for diagnosing strep throat, especially if RAT is negative, but clinical suspicion remains high. No specific tests for viral pharyngitis. Diagnosis is often based on the absence of bacterial signs and the presence of viral symptoms, e.g., cough, conjunctivitis. Treatment, viral pharyngitis, symptomatic treatment including rest, hydration, and over-the-counter pain relievers like ibuprofen or acetaminophen. Bacterial pharyngitis, antibiotics such as penicillin or amoxicillin are the mainstay for bacterial infections to prevent complications and hasten recovery. Prognosis. Both viral and bacterial pharyngitis typically resolve within 5 to 10 days, though bacterial infections can lead to complications such as rheumatic fever or peritonsillar abscess if untreated. High yield points. Viral pharyngitis often presents with a constellation of cold symptoms, including cough and nasal congestion, whereas bacterial pharyngitis, particularly strep throat, is characterized by high fever, absence of cough, and possible tonsillar exudate. The presence of anterior cervical lymphadenopathy, fever, absence of cough, and tonsillar exudates, center criteria, increase the likelihood of bacterial etiology, guiding the need for further diagnostic testing and potential antibiotic therapy. Management of viral pharyngitis focuses on symptom relief, while bacterial pharyngitis requires antibiotic treatment to reduce the risk of complications and transmission. Neck stiffness in a 4-year-old child presenting to the emergency department ED can be a sign of several serious conditions. It's crucial to rapidly assess and differentiate among these possibilities to provide appropriate care. Meningitis. A. Symptoms and pathophysiology. Fever and chills, often high grade. Altered mental status, confusion, irritability, or decreased consciousness. Photophobia, sensitivity to light. Headache, can be severe. Vomiting may occur due to increased intracranial pressure. Positive Kernig's and Brudzinski's signs, indicative of meningeal irritation. Encephalitis. A. Symptoms and pathophysiology, neurological symptoms, seizures, weakness, or altered motor function, behavioral changes, irritability, confusion, or hallucinations. Fever may be present, similar to meningitis. Subarachnoid hemorrhage, A. Symptoms and pathophysiology, sudden severe headache, often described as the worst headache of my life. Vomiting can occur without nausea. Seizures may be present in some cases. Intracranial abscess, symptoms and pathophysiology, fever, usually present, localized neurological deficits depending on the abscess location, altered mental status, ranging from mild confusion to severe impairment. Cervical spine injury or instability. A. Symptoms and pathophysiology, history of trauma, such as a fall or motor vehicle accident. Restricted neck movement due to pain or mechanical instability. Neurological deficits, such as numbness or weakness in the limbs. Torticollis. A. Symptoms and pathophysiology, abnormal head posture, typically head tilt to one side with chin pointed to the opposite shoulder. Neck pain may or may not be present. Limited neck movement, especially when trying to correct the head posture. Diagnostic approach, lumbar puncture, to analyze cerebrospinal fluid, CSF, for signs of infection, hemorrhage, or increased intracranial pressure. CT MRI of the head and neck to visualize structural abnormalities, abscesses, or signs of trauma. Blood tests, including complete blood count, electrolytes, and markers of infection. Treatment. Meningitis encephalitis, empirical antibiotic and/or antiviral therapy depending on suspected etiology. SAH, neurosurgical evaluation for potential intervention. Intracranial abscess, surgical drainage and antibiotics. Cervical spine injury, stabilization and potential surgical intervention. Torticollis, physical therapy and treatment of the underlying cause if identified. Prognosis varies widely depending on the specific diagnosis and the timeliness of intervention. High yield points. Neck stiffness in a child is a medical emergency, warranting immediate evaluation for life-threatening conditions like meningitis, encephalitis, or SAH. A thorough history, including recent infections, trauma, or neurological symptoms, and physical examination, focusing on neurological and meningeal signs, guide the initial diagnostic approach. Early imaging and lumbar puncture can be crucial in establishing the diagnosis, with the management tailored to the specific underlying condition. For an 18-month-old child who has recently been exposed to chickenpox, varicella, there are specific prophylactic measures that can be considered to prevent or mitigate the disease, especially if the child has not yet been vaccinated against varicella, as per the typical immunization schedule. Here are the options. Varicella vaccine. Eligibility. Children can receive the varicella vaccine as part of the routine immunization schedule starting at 12 months of age. If the child has not received the first dose, post-exposure vaccination can be considered. Timing. The vaccine is most effective if administered within 3 to 5 days of exposure, but may be given up to 10 days after exposure to possibly prevent the disease or make it less severe. Considerations. If the child has already received their first dose of the varicella vaccine, the exposure might result in a milder case of chickenpox or none at all. However, 2 doses of the vaccine provide the best protection. Varicella zoster immune globulin, Z. Eligibility. VZIG is recommended for high-risk individuals who have been exposed to chickenpox and are susceptible to severe varicella, including immunocompromised individuals, neonates whose mothers have symptoms of varicella around the time of delivery, premature infants, and certain pregnant women. For generally healthy children like an 18-month-old, VZIG is not routinely recommended. Timing. If indicated, VZIG should be administered as soon as possible after exposure, ideally within 96 hours to be most effective, but it can be given up to 10 days post-exposure. Considerations? The use of VZIG in a healthy child is typically not necessary, but may be considered in certain high-risk situations as determined by a healthcare professional. Antiviral medication. Eligibility. Antiviral medications like acyclovir are generally not recommended for otherwise healthy children who contract chickenpox. These medications are reserved for those at risk of severe varicella, such as immunocompromised patients, or those with severe skin conditions or respiratory problems. Timing. If antiviral treatment is considered necessary, it is most effective when started within 24 hours of the onset of the rash, and usually not indicated once the lesions have crusted over. Considerations. The use of antiviral prophylaxis in children after exposure to chickenpox is not standard practice and would only be considered under special circumstances as advised by a healthcare provider. General recommendations. Monitoring. Watch for signs of chickenpox, which typically appear 10 to 21 days after exposure. Early signs include fever, fatigue, loss of appetite, and a generalized rash that progresses to itchy blisters. Isolation. If chickenpox develops, keep the child isolated from others, especially from individuals who are at high risk for severe disease, such as pregnant women, newborns, and immunocompromised individuals, until all lesions have crusted over. High yield points. Post-exposure vaccination with the varicella vaccine can potentially prevent the disease or lessen its severity if given within 3 to 5 days, and possibly up to 10 days after exposure. VZIG is not routinely used for healthy children exposed to chickenpox, but may be considered for high-risk cases. Antiviral prophylaxis is not typically recommended for healthy children exposed to chickenpox. Monitoring for symptoms and isolating affected children from vulnerable populations are key steps in managing chickenpox exposure.
Cow's milk protein allergy, CMPA, in infants can manifest with a range of symptoms affecting multiple organ systems. It's crucial to recognize these signs as CMPA can significantly impact an infant's growth and well-being. A. Gastrointestinal symptoms: vomiting and regurgitation. Frequent vomiting or spit-ups that seem more forceful or more frequent than typical infant reflux. Diarrhea can be frequent and may contain blood or mucus. Constipation, infrequent hard or painful bowel movements. Abdominal pain, manifested as excessive crying, especially after feeding and drawing legs up to the belly. B. Skin manifestations: atopic dermatitis, eczema, dry, itchy, red skin patches, commonly on the face, scalp, and extremities. Urticaria, hives, red, raised, itchy bumps that may appear suddenly after feeding. C. Respiratory symptoms: wheezing or stridor. Noisy breathing that may suggest airway involvement. Persistent coughing, especially if not related to a cold. Nasal congestion, runny or stuffy nose without signs of a cold or flu. D. Systemic and other symptoms: failure to thrive, poor weight gain or weight loss, indicating inadequate nutrition or absorption. Anaphylaxis, rare, severe, life-threatening allergic reaction characterized by difficulty breathing, swelling of the mouth and throat, and a sudden drop in blood pressure. Colic, excessive, unexplained crying for more than 3 hours a day, more than 3 days a week, for more than 3 weeks. Diagnostic approach: dietary elimination and reintroduction, removing cow's milk protein from the infant's or breastfeeding mother's diet and observing if symptoms improve, followed by reintroduction to see if symptoms recur. Skin prick tests can help diagnose IgE-mediated CMPA, specific IgE blood tests to identify antibodies against cow's milk protein. Patch test for diagnosing non-IgE-mediated CMPA. Treatment: elimination diet, completely avoiding cow's milk and products containing cow's milk proteins. For breastfeeding mothers, this includes eliminating dairy from their diet. Hydrolyzed formula for formula-fed infants, using extensively hydrolyzed or amino acid-based formulas under medical supervision. Nutritional support, ensuring adequate nutrition through appropriate dietary substitutes to support growth and development. Prognosis, good with appropriate management. Many infants outgrow CMPA by the age of 3 to 5 years. High yield points. CMPA can present with a wide range of symptoms, including gastrointestinal distress, skin eruptions, and respiratory issues. A careful dietary elimination and reintroduction plan is essential for diagnosis, often coupled with supportive diagnostic tests. Management primarily involves the avoidance of cow's milk protein and the use of specialized formulas or dietary adjustments for breastfeeding mothers. Acute pancreatitis is a sudden inflammation of the pancreas that can be mild or life-threatening. Here are the characteristic features. A. Characteristic symptoms and pathophysiology. Severe upper abdominal pain, typically the hallmark symptom, often described as a constant piercing pain radiating to the back. Pain aggravation worsens after eating, especially high-fat foods, and when lying flat on the back. Abdominal tenderness and distension. The abdomen may be swollen and tender to touch due to inflammation and fluid accumulation. B. Clinical presentation and diagnosis. Nausea and vomiting often accompanies the abdominal pain. Fever. Low-grade fever is common. Jaundice. Yellowing of the skin and eyes, although less common, may occur if the bile duct becomes involved. Rapid pulse due to dehydration and pain. Diagnostic tests, blood tests, elevated levels of pancreatic enzymes, amylase, and lipase are indicative. Abdominal imaging. CT scan is the most common method to confirm the diagnosis and assess the severity. Ultrasound may be used to identify gallstones, a common cause of pancreatitis. MRI can provide detailed images of the bile ducts and pancreas. C. Treatment. Hospitalization. Most cases require admission for close monitoring and treatment. Fluids. Intravenous IV fluids to prevent dehydration. Fasting. To rest the pancreas, not eating for a few days might be recommended. Pain management with medications. Treating the underlying cause, such as gallstone removal or cessation of alcohol intake. Nutritional support. Initially, IV nutrition may be needed, transitioning to a low-fat diet. Deprognosis varies, depending on severity and underlying cause. Mild cases often resolve with treatment, but severe cases can lead to serious complications. Differential diagnosis table. Condition. Distinguishing features. Acute pancreatitis. Severe abdominal pain. Elevated amylase and lipase. Peptic ulcer disease. Epigastric pain, often relieved by eating or antacids. Acute cholecystitis. Right upper quadrant pain. Fever, positive Murphy sign. Acute appendicitis. Right lower quadrant pain, rebound tenderness. Gastroenteritis. Diarrhea, vomiting, crampy abdominal pain. High yield points. The onset of acute pancreatitis is often marked by sudden, severe upper abdominal pain, nausea, and vomiting. Diagnosis is primarily based on elevated serum amylase and lipase levels, along with characteristic imaging findings. Management includes supportive care with a focus on hydration, pain control, and dietary modifications, alongside treatment of the underlying cause. The course of acute pancreatitis can vary greatly, from mild cases that resolve with minimal intervention to severe cases that can lead to complex complications and require intensive care. Acute abdominal pain in infants can be challenging to assess due to their limited ability to communicate. Symptoms may vary widely depending on the underlying cause. Here are key indicators and possible associated conditions. A. General symptoms. Crying and irritability. Persistent or intense crying can be a sign of discomfort or pain. An infant may cry more than usual or have a high-pitched, inconsolable cry. Facial expressions. Grimacing, wincing, or a pained expression when touched or moved. Physical posturing. Pulling legs up towards the abdomen, arching the back, or assuming a fetal position can indicate abdominal discomfort. B. Associated symptoms. Vomiting. May range from mild spit-ups to forceful vomiting, depending on the cause. Diarrhea or constipation. Changes in bowel movements, presence of blood or mucus in the stool. Feeding difficulties. Refusal to eat, fussiness during feeds, or vomiting after eating. Fever may be present, indicating an infectious cause. Distended abdomen, swelling or bloating of the belly. Lethargy, reduced activity level, seeming unusually sleepy or unresponsive. C. Common causes and specific signs. 1. Intussusception, sudden onset of severe intermittent abdominal pain. Current jelly stools, blood and mucus, a palpable mass in the abdomen. 2. Volvulus, malrotation, sudden severe pain. Vomiting, which may be bilious, green. 3. Acute gastroenteritis, diarrhea, possibly with vomiting. Fever, dehydration. 4. Incarcerated hernia, a bulge in the groin or umbilical area that is painful and cannot be pushed back in. 5. Urinary tract infection, fever without clear cause, fussiness, vomiting, feeding difficulties. 6. Necrotizing enterocolitis, primarily in preterm infants, distended tender abdomen, bloody stools, lethargy. D. Diagnostic approach, physical examination, looking for signs of distension, masses, and hernias. Laboratory tests. Blood tests for infection, stool tests for blood or infection, urine tests for UTIs. Imaging. Ultrasound for intussusception or volvulus, X-rays for intestinal obstructions, gas patterns. Treatment, based on the underlying cause, ranging from surgical intervention, e.g. for intussusception volvulus, to medical management, e.g. antibiotics for UTI, rehydration for gastroenteritis. High yield points. Acute abdominal pain in infants requires prompt evaluation to rule out life-threatening conditions like intussusception or volvulus. Key signs include inconsolable crying, vomiting, abnormal stools, fever, and changes in feeding patterns. The physical examination and appropriate imaging are crucial in diagnosing the underlying cause. Treatment is cause-specific, with some conditions requiring urgent surgical intervention. Acute abdominal pain in school-aged children can have a variety of causes, ranging from benign to serious. Understanding the presentation and associated symptoms is crucial for prompt diagnosis and management. A. General symptoms. Localized or diffuse pain. Pain may be specific to one area, like the right lower quadrant in appendicitis, or it may be diffuse, as seen in gastroenteritis. Intensity and nature of pain can vary from mild to severe and may be described as sharp, stabbing, or cramping. B. Associated symptoms. Nausea and vomiting, common in many gastrointestinal conditions. Diarrhea or constipation may indicate a gastrointestinal disturbance. Fever suggests an infectious process. Loss of appetite often accompanies abdominal pain. Changes in urination. Pain, frequency, or urgency can indicate a urinary tract infection. See specific conditions and their signs. 1. Appendicitis. Pain starting around the navel, moving to the right lower quadrant. Fever, nausea, and possibly vomiting. Rebound tenderness, pain upon releasing pressure on the abdomen. 2. Gastroenteritis. Diarrhea, vomiting, crampy abdominal pain, dehydration signs such as decreased urination, dry mouth, lethargy. 3. Constipation, infrequent bowel movements, hard, dry stools. Abdominal pain relieved by defecation. 4. Urinary tract infection, UTI. Dysuria, painful urination. Urgency and frequency of urination. Lower abdominal pain, fever. 5. Intussusception, episodes of severe abdominal pain that come and go. Current jelly stools, blood and mucus. Vomiting and lethargy. 6. Mesenteric lymphadenitis. Pain often mimics appendicitis, right lower quadrant. Fever, possibly sore throat or other upper respiratory symptoms preceding abdominal pain. D. Diagnostic approach. Clinical examination, including palpation of the abdomen to identify tenderness, distension, or masses. Laboratory tests. Complete blood count, CBC, for signs of infection. Urinalysis for UTI. Imaging. ultrasound for conditions like appendicitis or intussusception, X-ray for constipation or to rule out other causes. Treatment depends on the underlying cause, may range from surgical intervention, e.g. for appendicitis, to supportive care, e.g. hydration for gastroenteritis, and medication, e.g. antibiotics for UTI. High yield points. A thorough history and physical examination are essential in differentiating the causes of acute abdominal pain in school-age children. Specific signs and symptoms, such as the location of pain, presence of fever, and gastrointestinal symptoms, can guide diagnosis. Appendicitis is a common cause of surgical abdominal pain in this age group, necessitating prompt recognition and referral. The treatment is tailored to the underlying cause, with some conditions requiring emergency intervention. Constipation in preschool-age children often presents with symptoms that can affect the child's comfort and overall well-being. Recognizing these signs is crucial for timely and effective management. A. Bowel movement patterns. Infrequent bowel movements, less than 3 times a week. Difficulty passing stools. The child may express discomfort, pain, or strain during bowel movements. Hard, dry stools, often described as pellet-like, making them difficult to pass. B. Abdominal symptoms. Abdominal pain, discomfort or pain, especially before or during bowel movements. Bloating. A sensation of fullness or swelling in the abdomen. Visible discomfort. The child might appear visibly uncomfortable, especially during attempts to pass stools. C. Behavioral signs. Stool withholding behaviors, such as squatting, crossing legs, or refusing to sit on the toilet, often due to fear of painful defecation. Avoidance of bowel movements. The child may avoid going to the bathroom due to previous painful experiences. D. Other associated symptoms. Soiling or fecal incontinence. Unintentional passage of small amounts of stool due to overflow constipation. Lack of appetite, due to abdominal discomfort or feeling of fullness. Nausea. In some cases, severe constipation can lead to a feeling of nausea. E. Contributing factors. Dietary habits. Low intake of fiber-rich foods such as fruits, vegetables, and whole grains. Fluid intake. Insufficient consumption of fluids. Toilet training issues. Stress or reluctance related to toilet training can contribute to constipation. Physical activity. Reduced physical activity can exacerbate constipation. F. Management strategies. Dietary modifications. Increasing the intake of fiber-rich foods and ensuring adequate hydration. Encouraging regular toilet times. Establishing a routine can help promote regular bowel movements. Physical activity. Encouraging regular physical activity to stimulate bowel movements. Positive reinforcement. Using positive reinforcement to encourage sitting on the toilet and attempting bowel movements. G. When to seek medical advice. Persistent symptoms. If constipation persists despite home management, or if there are concerns about the child's growth or well-being. Severe pain or vomiting. These symptoms could indicate a more serious underlying condition. High yield points. Constipation in preschool children is often characterized by infrequent, difficult, and painful bowel movements with hard, dry stools. Recognizing behavioral signs of stool withholding is important for early intervention. Management focuses on dietary and lifestyle changes, including increased fiber and fluid intake, regular toilet routines, and physical activity. Persistent or severe constipation warrants medical evaluation to rule out underlying conditions and discuss additional treatment options. Abdominal pain in children is a common complaint, but certain red flags may indicate a more serious underlying condition requiring urgent medical attention. Here are key red flags to watch for. A. Severe symptoms. Intense, persistent pain. Severe abdominal pain that is constant or significantly disrupts normal activity. Pain worsening over time. Pain that becomes progressively worse rather than improving or fluctuating in intensity. B. Associated symptoms. Vomiting, especially if it's persistent, green, bilious, or contains blood. Bloody stools, red or black, tarry, stools can indicate bleeding in the gastrointestinal tract. High fever, especially when accompanied by abdominal pain, suggesting an infectious or inflammatory process. Weight loss or failure to thrive, indicative of a chronic condition or significant illness. Distended abdomen, swelling or bloating of the abdomen, which may indicate obstruction, ascites, or significant organ enlargement. C. Location and nature of pain. Localized pain. Pain localized to one specific area, e.g., right lower quadrant pain could suggest appendicitis. Rebound tenderness. Increased pain when pressure is removed from the abdomen, suggesting peritoneal irritation. D. Systemic signs. Jaundice. Yellowing of the skin or eyes, indicating liver or biliary disease. Pallor. Pale appearance can suggest anemia or shock. Rash. Certain rashes, like the purpuric rash of Hennock-Schönlein purpura, can be associated with systemic illness. Other concerning features. Nighttime symptoms. Pain that wakes the child from sleep can be more concerning than pain only occurring during the day. Pain unrelated to meals. Pain that doesn't correlate with eating may suggest a non-gastrointestinal source. Family history. A significant family history of gastrointestinal diseases, cancers, or hereditary conditions. F. Urgent situations. Signs of shock, such as rapid pulse, cold extremities, and decreased alertness, indicating a potentially life-threatening condition. Signs of dehydration, including decreased urination, dry mouth, and lethargy, especially in the context of vomiting or diarrhea. High yield points. Recognizing red flags in pediatric abdominal pain is crucial for early identification of serious conditions requiring urgent evaluation. Persistent, localized, or severe pain, especially when associated with systemic symptoms like fever, vomiting, and changes in stool or urine, warrants immediate medical attention. A thorough history and physical examination are essential to identify these red flags and guide further diagnostic and therapeutic interventions. Celiac disease is an autoimmune disorder triggered by the ingestion of gluten, a protein found in wheat, barley, and rye. The condition can manifest with a wide range of symptoms and signs affecting various systems of the body. A. Gastrointestinal symptoms. Chronic diarrhea, loose, watery stools that may persist. Abdominal pain, recurrent pain and discomfort in the abdominal area. Bloating and gas, distension and discomfort due to excessive gas. Constipation can also occur, often alternating with diarrhea. Steatorrhea, fatty stools that are often foul-smelling and may float due to poor fat absorption. Nausea and vomiting, particularly in children. B. Dermatological signs. Dermatitis herpetiformis, itchy, blistering skin rash, typically on elbows, knees, and buttocks. This is considered pathognomonic for celiac disease. C. Growth and developmental concerns in children. Failure to thrive. Inadequate weight gain and physical growth in infants and young children. Delayed puberty in older children and adolescents. Dental enamel defects, abnormalities in the enamel of the teeth. D. Neurological symptoms, fatigue, persistent tiredness that is not relieved by rest. Headaches and migraines, frequent or chronic headaches. Neurological impairments, such as peripheral neuropathy, tingling or numbness in hands and feet, and ataxia, impaired balance. Nutritional deficiencies, anemia, often due to iron deficiency resulting from malabsorption. Osteopenia or osteoporosis, due to malabsorption of calcium and vitamin D, leading to weakened bones. Deficiencies of vitamins B12, D, and K can lead to various symptoms, including fatigue and bleeding disorders. F. Reproductive issues, infertility, both in males and females. Recurrent miscarriage in women with untreated celiac disease. Other associated conditions, autoimmune disorders, increased risk of type 1 diabetes, autoimmune thyroid disease, and others. Lactose intolerance, secondary to villus atrophy. Diagnostic approach, serologic tests, screening with tissue transglutaminase antibodies, TTG, IgA, and others. Endoscopic biopsy, confirmation by small bowel biopsy showing villus atrophy, crypt hyperplasia, and lymphocyte infiltration. Genetic testing for HLA-DQ2 and HLA-DQ8, which are necessary but not sufficient for the development of celiac disease. Management, gluten-free diet. Strict lifelong adherence to a diet free from gluten is the cornerstone of management. Nutritional support, addressing and correcting nutritional deficiencies. High yield points. Celiac disease can present with a wide array of symptoms beyond classic gastrointestinal issues, including dermatological, neurological, and systemic manifestations. Diagnosis involves a combination of serologic testing and confirmatory small bowel biopsy. The only effective treatment for celiac disease is a strict, lifelong gluten-free diet, which can lead to symptom resolution and prevention of complications. Inflammatory bowel disease, IBD, which includes Crohn's disease and ulcerative colitis, can present with various symptoms in a 15-year-old girl. The manifestations may vary depending on the type and severity of the disease, as well as the specific areas of the gastrointestinal tract involved in Crohn's disease, or the extent of the colon involvement in ulcerative colitis. A. Gastrointestinal symptoms. Abdominal pain and cramping, often in the lower right abdomen for Crohn's disease, and may be more diffuse in ulcerative colitis. Diarrhea can be persistent and may contain blood, especially in ulcerative colitis. Rectal bleeding, more common in ulcerative colitis, but can occur in Crohn's disease if the lower part of the intestine is involved. Urgency to defecate, particularly noted in ulcerative colitis. Constipation can occur in Crohn's disease, especially if there is significant involvement of the small intestine. B. Systemic symptoms, weight loss, due to reduced appetite and malabsorption of nutrients. Fatigue, a common complaint, often due to anemia or the chronic inflammatory state. Fever may occur, especially during flare-ups. C. Growth and development, delayed growth or puberty, due to chronic inflammation and malnutrition. D. Extraintestinal manifestations, joint pain, arthritis, particularly in the larger joints. Skin disorders, such as erythema nodosum, tender red nodules usually on the shins, and pyoderma gangrenosum, painful skin ulcers. Eye inflammation, including uveitis, which can cause eye pain and vision changes. Mouth ulcers can be recurrent. E. Complications, strictures, particularly in Crohn's disease, leading to bowel obstruction symptoms like severe cramping and bloating. Fistulas, more common in Crohn's disease, can lead to infections and abscesses. Increased risk of colorectal cancer, especially with long-standing ulcerative colitis. Diagnostic approach, blood tests, looking for signs of inflammation, elevated CRP, ESR, and anemia. Stool tests to check for blood in the stool and to rule out infections. Endoscopy and colonoscopy, with biopsies to visualize the extent of inflammation and obtain tissue samples for definitive diagnosis. Imaging studies, such as MRI or CT scans to assess the small intestine in Crohn's disease or complications in both conditions. Management, medication, including aminosalicylates, corticosteroids, immunomodulators, and biologic therapies aimed at reducing inflammation. Nutritional support, to address and prevent malnutrition. Surgery may be necessary for complications like strictures, fistulas, or significant colorectal dysplasia or cancer. High yield points. In a 15-year-old girl with IBD, symptoms can range from gastrointestinal complaints like abdominal pain and diarrhea to systemic effects such as weight loss and fatigue. Extraintestinal manifestations, including joint, skin, and eye involvement, highlight the systemic nature of IBD. Management is multifaceted, involving medical therapy to control inflammation and surgical interventions for complications, with a significant focus on maintaining nutritional health and monitoring for growth delays. Pyloric stenosis, often seen in infants a few weeks old, is a condition where the pylorus muscles thicken, obstructing food from entering the small intestine. Here are the typical symptoms. A. Gastrointestinal symptoms. Projectile vomiting, forceful expulsion of milk or formula several feet away, occurring shortly after feeding. This is the hallmark symptom. Constant hunger. Infants may seem hungry frequently due to vomiting up their feedings. Physical signs. Olive-sized mass, palpable in the upper abdomen, representing the enlarged pylorus. Visible peristalsis, wave-like movements of the abdomen after feeding, as the stomach tries to force contents past the narrowed pylorus. C. Dehydration and electrolyte imbalance. Dehydration signs, such as fewer wet diapers, dry mouth, sunken eyes, or a sunken fontanelle in the infant's skull. change in urination, decreased frequency and volume of urination, weight loss or failure to gain weight due to vomiting and inadequate intake. D. Metabolic consequences, metabolic alkalosis, due to the loss of stomach acid, hydrochloric acid, from persistent vomiting, leading to an imbalance in the body's electrolytes, particularly characterized by low chloride and potassium levels. E. Behavioral changes, irritability or lethargy, depending on the severity of dehydration and electrolyte imbalance. Diagnostic approach, physical examination. Palpation of the abdomen may reveal the characteristic olive-sized mass. Ultrasound, a non-invasive test that can visualize the thickened pylorus. Blood tests, to assess for dehydration and electrolyte imbalances, especially metabolic alkalosis. High yield points. Projectile vomiting in an otherwise healthy infant a few weeks old is highly suggestive of pyloric stenosis. The condition requires prompt medical evaluation due to the risk of dehydration and electrolyte imbalances. Treatment typically involves surgical intervention, known as pyloromyotomy, to relieve the obstruction, which is usually curative with an excellent prognosis. Gastroesophageal reflux, GR, and gastroesophageal reflux disease, GERD, in infants share common features but differ significantly in terms of severity, impact on health, and need for medical intervention. Understanding these differences is crucial for appropriate management. Gastroesophageal reflux, RA, characteristics, physiological phenomenon, common in healthy infants, reflecting the frequency of regurgitation or spitting up due to an immature lower esophageal sphincter. Symptom presentation typically manifests as effortless spitting up after meals, which doesn't distress the infant. Feeding and growth. Infants continue to feed well and demonstrate normal growth patterns. B. Management, lifestyle and feeding changes. Often, simple measures like frequent burping, upright positioning after feeds, and ensuring appropriate feeding volume and technique are sufficient. Observation. Most infants outgrow GER by 12 to 18 months of age as the lower esophageal sphincter matures. Gastroesophageal reflux disease. A. Characteristics. Pathological condition. GER becomes GERD when the reflux episodes are frequent and severe enough to cause symptoms or complications, impacting the infant's well-being. Symptom severity. Symptoms may include persistent vomiting, pronounced irritability during or after feeds, refusal to eat, failure to thrive, or respiratory symptoms, e.g. wheezing, coughing, or recurrent pneumonia due to aspiration of gastric contents. Esophageal irritation. In some cases, exposure to stomach acid can lead to esophagitis, causing pain and discomfort. B. Management. Medical evaluation. Necessary to distinguish GERD from other conditions with similar symptoms and to assess for complications. Treatment options. In addition to lifestyle and dietary changes, medical treatment may include acid-suppressing medications like H2 blockers or proton pump inhibitors, PPIs, in more severe cases. Specialist referral. In cases of poor weight gain, significant respiratory symptoms, or failure of medical management, referral to a pediatric gastroenterologist may be warranted. High yield points. GER in infants is common and usually resolves on its own with simple management strategies focused on feeding and positioning. GERD in infants is characterized by more severe symptoms that can impact feeding, growth, and overall health, potentially requiring medical treatment. Distinguishing between GER and GERD is essential to avoid unnecessary medical interventions in typical cases of GER while providing appropriate care for infants with GERD. Heart failure in infants can be challenging to recognize due to the subtlety of symptoms and the inability of infants to communicate their discomfort. Symptoms often result from the heart's inability to pump efficiently, leading to poor systemic perfusion and congestion. Key signs include A. Feeding difficulties. Poor feeding. Infants may tire easily during feeding or may not be able to finish feeds due to fatigue or breathlessness. Sweating, notably around the head, especially during feeding or physical activity. B. Respiratory symptoms. Tachypnea, increased respiratory rate even at rest. Dyspnea, labored breathing, which may be observed as flaring nostrils, grunting, or retractions in drawing of the chest wall. Frequent respiratory infections. Infants with heart failure may be more prone to developing bronchiolitis, pneumonia, and other respiratory conditions. C. Growth and development. Failure to thrive. Poor weight gain or weight loss, and possibly delayed milestones due to inadequate nutrition and oxygen delivery to tissues. D. Cardiovascular signs. Tachycardia, persistently elevated heart rate. Cardiomegaly, enlargement of the heart, which may be detected on a physical examination or imaging studies. Murmur, heart murmurs may be detected, indicating underlying structural heart problems. E. Congestion symptoms. Hepatomegaly, enlarged liver, which may be palpable below the right costal margin. Edema, swelling of the lower extremities, abdomen, ascites, or in severe cases, generalized swelling, anasarca. Venous distension. Jugular venous distension is difficult to assess in infants, but may be noted in older children. F. Other symptoms. Cyanosis, a bluish tint to the skin, lips, and nail beds, indicating low oxygen levels, particularly noted in infants with congenital heart defects, causing right-to-left shunts. Diaphoresis, excessive sweating, which may be more pronounced during feeding or crying. Irritability or lethargy. Infants may appear more irritable or, conversely, unusually sleepy or lethargic due to reduced cardiac output and oxygen delivery to the brain. Diagnostic approach. Clinical examination, assessing for signs of congestion, respiratory distress, and cyanosis. Chest X-ray may reveal cardiomegaly or pulmonary congestion. Echocardiogram, essential for diagnosing structural heart disease and assessing cardiac function. Electrocardiogram, ECG, can provide information on heart rhythm and, indirectly, heart size. Blood tests, including B-type natriuretic peptide, BNP levels, which are elevated in heart failure. Management involves a multidisciplinary approach, including pediatric cardiologists and, if necessary, cardiac surgeons. Treatment options may include medications, e.g. diuretics, ACE inhibitors, digoxin, interventions to correct structural abnormalities, and in severe cases, heart transplantation. High yield points. Symptoms of heart failure in infants often revolve around poor feeding, growth failure, respiratory distress, and signs of systemic venous congestion. Early recognition and intervention are crucial to manage symptoms and address any underlying causes to improve outcomes. Myocarditis in infants, an inflammatory condition of the heart muscle often caused by viral infections, can present with varied and sometimes subtle symptoms. Recognizing these signs is crucial for timely diagnosis and management. A. General symptoms. Fever may be one of the initial signs, often accompanied by other symptoms of viral infection, such as runny nose, cough, or gastrointestinal upset. Irritability. Infants may appear more fussy or irritable than usual. Lethargy. Decreased activity levels or increased sleepiness, indicating decreased cardiac output and poor perfusion. B. Feeding difficulties. Poor feeding. Difficulty feeding or reduced appetite, which may lead to poor weight gain or weight loss. Fatigue during feeding. Tiring easily during feeds due to the increased energy expenditure associated with heart dysfunction. C. Respiratory symptoms. Tachypnea. Increased respiratory rate, even at rest, due to the heart's reduced ability to pump effectively. Dyspnea. Labored breathing, which might be observed as grunting, flaring of the nostrils, or intercostal retractions in drawing of the areas between the ribs during breathing. Cough may develop, potentially with frothy or blood-tinged sputum in severe cases. D. Cardiovascular signs. Tachycardia, elevated heart rate not explained by fever or stress. Muffled heart sounds. Diminished heart sounds on auscultation due to the presence of fluid in the pericardial space, in cases where myocarditis is associated with pericardial effusion. Arrhythmias. Irregular heartbeats can occur due to inflammation and irritation of the heart muscle. E. Other possible signs. Hepatomegaly, an enlarged liver due to congestion from heart failure. Peripheral edema, swelling of the extremities, although this might be less common in infants. Cyanosis, a bluish discoloration of the skin, lips, and nail beds, indicating inadequate oxygenation, may be seen in severe cases. Diagnostic approach. Clinical examination. Initial assessment of symptoms and physical signs. Chest X-ray may reveal an enlarged cardiac silhouette and signs of pulmonary congestion. Electrocardiogram, ECG, can show arrhythmias or other changes indicative of myocardial irritation or injury. Echocardiography, essential for evaluating cardiac structure and function, may show decreased ventricular function. Blood tests, including markers of cardiac injury, troponins, inflammation, CRP, ESR, and possibly specific viral titers. Endomyocardial biopsy, considered the gold standard for diagnosis, but rarely performed due to its invasiveness and risk, particularly in small infants. Management, supportive care, ensuring adequate oxygenation and circulation. This may include oxygen therapy, diuretics, and medications to support heart function. Immunomodulatory therapy. In some cases, treatment may include IVIG, intravenous immunoglobulin, or corticosteroids, especially if there is a confirmed autoimmune component. Monitoring and follow-up. Close monitoring for potential complications, such as dilated cardiomyopathy. High yield points. Myocarditis in infants can present with nonspecific signs like fever, irritability, and poor feeding, alongside more direct indicators of cardiac distress, such as tachycardia and respiratory difficulties. Diagnosis involves a combination of clinical assessment, imaging, and laboratory tests to evaluate cardiac function and inflammation. Management primarily focuses on supportive care to maintain hemodynamic stability and treat the underlying cause, with careful monitoring for potential long-term sequelae. Management of heart defects in neonates is crucial, as some congenital heart diseases, CHDs, can lead to significant morbidity and mortality if not addressed promptly. The following list includes common and critical CHDs that often require early intervention or management in the neonatal period. 1. Patent ductus arteriosus, PDA, a persistent opening between the aorta and pulmonary artery which can lead to heart failure and inadequate oxygenation of the body. 2. Tetralogy of Fallot, 2F, a combination of 4 heart defects that result in oxygen-poor blood being pumped to the body, potentially requiring early surgery. 3. Transposition of the great arteries, a condition where the 2 main arteries leaving the heart are reversed, requiring urgent arterial switch operation for survival. 4. Total anomalous pulmonary venous return, TAVR. Pulmonary veins do not connect normally to the left atrium, often requiring surgery in the early neonatal period. Number 5. Hypoplastic left heart syndrome, HLHS. Underdevelopment of the left side of the heart, requiring staged surgical procedures starting in the first few days of life. 6. Coarctation of the aorta, narrowing of the aorta, which can lead to heart failure and poor blood flow to the lower part of the body, often necessitating surgical repair. 7. Truncus arteriosus. A single vessel comes out of the heart, mixing oxygen-rich and oxygen-poor blood, usually requiring surgery in the first few weeks of life. 8. Pulmonary atresia, absence or underdevelopment of the pulmonary valve, obstructing blood flow to the lungs and requiring immediate intervention. 9. Aortic stenosis, narrowing of the aortic valve, which can cause heart dysfunction and may require balloon valvuloplasty or surgery. 10. Ventricular septal defect, VSD, with hemodynamic instability. Large VSDs can lead to significant heart failure and pulmonary hypertension, sometimes necessitating early surgical closure. 11. Atrioventricular septal defect, AVSD, a defect involving atrial and ventricular septa and the atrioventricular valves, often associated with Down syndrome, may require surgery in the first few months of life, especially if symptomatic. 12. Interrupted aortic arch, a discontinuity of the aortic arch, a rare condition that requires surgical repair in the neonatal period to ensure survival. 13. Ebstein's anomaly, a rare heart defect affecting the tricuspid valve and right ventricle, which can lead to heart failure in neonates, sometimes requiring intervention. Management strategies for these conditions can include pharmacologic treatments, e.g., prostaglandin E1, to keep the ductus arteriosus open in conditions like TGA or HLHS, interventional catheterization procedures, e.g., balloon atrial septostomy for TGA or valvuloplasty for stenotic valves, and various forms of cardiac surgery, ranging from palliative procedures to definitive repair, depending on the specific defect and the condition of the infant. Neonatal management of CHDs requires a multidisciplinary approach involving neonatologists, pediatric cardiologists, and pediatric cardiac surgeons, among others. Cyanotic congenital heart diseases, CHDs, are characterized by a bluish discoloration of the skin and mucous membranes, cyanosis, due to decreased oxygenation of blood. This occurs when there is right-to-left shunting of blood, bypassing the lungs, or mixing of oxygen-poor and oxygen-rich blood within the heart or great vessels. Common cyanotic CHDs include 1. Tetralogy of Fallot, TOF, comprises ventricular septal defect, VSD, pulmonary stenosis, right ventricular hypertrophy, and an overriding aorta. 2. Transposition of the great arteries, TGA. The aorta and pulmonary artery are switched from their normal positions, leading to separate systemic and pulmonary circulations. 3. Tricuspid atresia, absence of the tricuspid valve, leading to underdevelopment of the right ventricle and hypoxemia. 4. Total anomalous pulmonary venous connection, TAPC. Pulmonary veins connect to the right atrium or its venous tributaries instead of the left atrium, causing oxygenated and deoxygenated blood to mix. 5. Truncus arteriosus. A single arterial trunk arises from the heart, supplying the systemic, pulmonary, and coronary circulations, with an inherent VSD causing mixing of blood. 6. Pulmonary atresia with intact ventricular septum. Complete obstruction of the pulmonary valve, preventing blood from flowing from the right ventricle into the pulmonary artery, often associated with right-to-left shunting through an atrial septal defect, ASD. 7. Hypoplastic left heart syndrome, HLHS. Underdevelopment of the left side of the heart, including the aorta, aortic valve, left ventricle, and mitral valve, leading to reliance on the patent ductus arteriosus for systemic circulation. 8. Ebstein's anomaly. A rare heart defect of the tricuspid valve leading to regurgitation and right-to-left shunt through an ASD, causing cyanosis. 9. Pulmonary atresia with ventricular septal defect, PAVSD. Absence of the pulmonary valve and presence of a VSD, leading to severe pulmonary stenosis or atresia and right-to-left shunting of blood. These conditions often present in the neonatal period or early infancy with varying degrees of cyanosis, respiratory distress, and heart failure, necessitating prompt diagnosis and management, which may include medical treatment, interventional catheterization, and/or surgical repair depending on the specific condition and severity. Hypertension in adolescence can arise from various causes, which can be broadly classified into primary, essential hypertension, and secondary hypertension. Here's a comprehensive overview. Primary hypertension. Genetic predisposition. A family history of hypertension increases the risk. Obesity. A significant and increasingly common risk factor in adolescence. Lifestyle factors. Poor diet, high in salt, fat, and processed foods, physical inactivity, and high stress levels. Insulin resistance, associated with obesity and can contribute to increased blood pressure. Secondary hypertension. Renal disorders. Chronic kidney disease, from conditions like glomerulonephritis, pyelonephritis, or congenital anomalies. Renal artery stenosis, narrowing of the arteries that supply the kidneys, can lead to increased renin production and hypertension. Polycystic kidney disease, inherited disorder characterized by the formation of cysts in the kidneys. Endocrine disorders, primary aldosteronism. Excessive production of aldosterone leads to sodium retention and potassium loss, increasing blood volume and pressure. Cushing's syndrome, excess cortisol production can increase blood pressure. Pheochromocytoma, a rare tumor of the adrenal gland causing excessive production of catecholamines, leading to episodes of hypertension. Thyroid disorders, both hypothyroidism and hyperthyroidism, can affect blood pressure. Congenital adrenal hyperplasia can lead to excess production of hormones that affect blood pressure. Cardiovascular causes. Coarctation of the aorta, a congenital narrowing of the aorta that can cause upper body hypertension. Aortic valve disease can affect blood pressure regulation. Sleep disorders. Obstructive sleep apnea, associated with obesity and can significantly contribute to hypertension. Medications and substances, prescription drugs, such as oral contraceptives, corticosteroids, and some psychiatric medications. Over-the-counter medications, including NSAIDs, decongestants, and weight loss drugs. Substance use, caffeine, alcohol, tobacco, and illicit drugs like amphetamines and cocaine. Others, systemic conditions, such as lupus or scleroderma, which can involve the kidneys and affect blood pressure. Identifying the underlying cause is crucial for managing hypertension in adolescence. While primary hypertension is managed with lifestyle modifications and, if necessary, pharmacotherapy, secondary hypertension requires treating the underlying disease to effectively control blood pressure. Maintaining patency of the ductus arteriosus, DA, in newborns, often achieved pharmacologically with prostaglandin E1, PGE1, is a critical intervention in specific congenital heart defects, CHDs, where the DA's closure can lead to life-threatening circulatory compromise. The DA is a fetal blood vessel connecting the pulmonary artery to the descending aorta, allowing blood to bypass the non-functioning fetal lungs. After birth, it typically closes within the first few days of life. However, in certain CHDs, keeping the DA open is essential for survival until definitive treatment can be provided. Indications include 1. Ductal-dependent pulmonary blood flow, pulmonary atresia, absence or severe obstruction of the pulmonary valve, preventing blood from flowing from the right ventricle into the lungs, tetralogy of Fallot with severe pulmonary stenosis, reduced blood flow to the lungs due to narrowing of the pulmonary valve and outflow tract, tricuspid atresia, absence of the tricuspid valve, with the DA providing the only route for pulmonary blood flow. 2. Ductal-dependent systemic blood flow, hypoplastic left heart syndrome, HLHS, underdevelopment of the left side of the heart with the DA allowing for systemic perfusion. Interrupted aortic arch, discontinuity of the aortic arch with the DA providing the only means for blood to reach the lower body. Critical coarctation of the aorta, severe narrowing of the aorta, where the DA supplies blood flow to the lower body. 3. Ductal-dependent mixing lesions, transposition of the great arteries, TGA. The aorta and pulmonary artery are switched, and an open DA allows for mixing of oxygenated and deoxygenated blood. Total anomalous pulmonary venous return, TAF-VR, with obstruction. Pulmonary veins drain into the right heart, and the DA provides an outlet for the mixed blood to reach the systemic circulation. 4. Complex congenital heart diseases, conditions involving severe underdevelopment, malposition, or obstruction of cardiac chambers or major vessels, where the DA's patency facilitates necessary blood flow or mixing until surgical intervention is possible. In all these conditions, the goal of maintaining ductal patency is to ensure adequate systemic oxygenation and perfusion, either by promoting pulmonary blood flow, systemic blood flow, or both. This intervention is typically a bridge to further diagnostic procedures, palliative surgery, or definitive corrective surgery. The decision to initiate prostaglandin therapy to maintain ductal patency is made after careful consideration of the newborn's specific cardiac anatomy, clinical presentation, and the urgency of the need for intervention. The vaccination schedule for the first year of life varies by country, but there are common vaccines that are typically administered during this period to protect infants from serious infectious diseases. Here's a list of vaccines commonly introduced in the first year, based on the United States Centers for Disease Control and Prevention, CDC schedule. Birth. Hepatitis B, Hep B vaccine. The first dose is usually given within 24 hours of birth. 1 to 2 months, hepatitis B, Hep vaccine. Second dose. The first dose was given at birth, and the second dose is typically given at 1 to 2 months of age. Rotavirus, RV vaccine. First dose. This vaccine protects against rotavirus, a leading cause of severe diarrhea in infants and young children. Diphtheria, tetanus, and acellular pertussis, DT vaccine. First dose. This combination vaccine protects against 3 bacterial diseases: diphtheria, tetanus, and pertussis, whooping cough. Haemophilus influenza type B vaccine, first dose. This vaccine protects against Haemophilus influenza type B, which can cause meningitis, pneumonia, and other serious infections. Pneumococcal conjugate vaccine, PCV13, first dose. This vaccine protects against pneumococcal bacteria, which can cause pneumonia, meningitis, and blood infections. Inactivated poliovirus, IPV vaccine, first dose. This vaccine protects against polio, a virus that can cause paralysis. 4 months. Second doses of RV, DTaP, Hib, PCV13, and IPV. 6 months. Hepatitis B vaccine, third dose. The timing can vary, but the final dose is usually administered between 6 and 18 months. Rotavirus RV vaccine, final dose. The second or third dose depending on the vaccine used. Diphtheria, tetanus, and acellular pertussis, DTaP vaccine, third dose. Haemophilus influenzae type B, Hib vaccine, third dose. For some Hib vaccines, this is the final dose. Pneumococcal conjugate vaccine, PCV13, third dose. Inactivated poliovirus IPV vaccine, third dose. 6 to 12 months, influenza vaccine, recommended annually for children 6 months of age and older. The initial vaccination requires 2 doses administered at least 4 weeks apart. It's important to consult with a healthcare provider for the most current and region-specific vaccination schedules, and for any additional vaccines that may be recommended based on local health guidelines and individual health considerations. Here's a table summarizing the vaccinations introduced in the first year of life, typically based on the United States CDC schedule. Age, vaccination, disease, protected against, summarizing the vaccinations introduced. Birth, hepatitis B. Hepatitis B, first dose, 1 to 2 months. Hepatitis B, second dose. Hepatitis B. Rotavirus, RV, first dose. DTaP, first dose. Diphtheria, tetanus, pertussis, whooping cough. Hib, first dose, Haemophilus influenzae type B, pneumococcal, PCV, first dose, pneumococcal diseases. Inactivated poliovirus, IPV, first dose polio. 4 months rotavirus RV, second dose rotavirus. DTaP, second dose, diphtheria, tetanus, pertussis. Hib, second dose, Haemophilus influenzae type B. Pneumococcal, PCV13, second dose, pneumococcal diseases. Inactivated poliovirus IPV, second dose, polio. 6 months, hepatitis B, Hep B, third dose, hepatitis B. Rotavirus RV, last dose, rotavirus, second or third dose, depending on vaccine. DTaP, third dose, diphtheria, tetanus, pertussis, whooping cough. Hib, third or final dose, Haemophilus influenzae type B, depends on the vaccine. Pneumococcal PCV13, third dose, pneumococcal diseases. Inactivated poliovirus, IPV, third dose polio. 6 to 12 months. Influenza, first dose. Influenza, flu. Influenza, second dose, if first vaccination. Influenza, flu, 4 weeks after the first dose, if first time vaccinated. This table reflects a typical schedule, but may vary based on regional guidelines, vaccine availability, and individual health considerations. Always consult healthcare providers for personalized advice and schedules. Sudden infant death syndrome, SIDS, is the unexplained death, usually during sleep, of a seemingly healthy infant less than a year old, typically between the ages of 1 and 4 months. Despite extensive autopsy, death scene investigation, and review of the clinical history, the cause of SIDS remains unknown, making it a diagnosis of exclusion. SIDS is a subcategory of sudden unexpected infant death, SUID, which also includes deaths from known causes. Key points about SIDS. Incidence. SIDS is one of the leading causes of death in infants between 1 month and 1 year of age in developed countries. Risk factors. While the exact cause is unknown, several risk factors have been identified, including prone, face down and side sleeping positions, soft sleeping surfaces, and loose bedding, overheating during sleep, maternal smoking during pregnancy and exposure to secondhand smoke after birth, premature birth or low birth weight, having a sibling who died from SIDS, being male, as slightly more male infants die from SIDS than females, infants who are not breastfed or have a shorter duration of breastfeeding. Preventive measures. Public health campaigns advocating for safe sleep practices have significantly reduced the incidence of SIDS. These include back to sleep, always placing infants on their backs for every sleep, for naps and at night. Firm sleep surface. Using a firm sleep surface, such as a mattress in a safety-approved crib covered by a fitted sheet. Room sharing without bed sharing. Keeping the infant's sleep area in the same room where parents sleep, but on a separate surface designed for infants. Keep soft objects and loose bedding away. No pillows, blankets, sheepskins, or crib bumpers anywhere in the baby's sleep area. Avoid overheating. Dressing the infant in sleep clothing that doesn't cause them to overheat and keeping the room at a comfortable temperature. Breastfeeding. Encouraging breastfeeding if possible. Consider offering a pacifier. Offering a pacifier at nap time and bedtime can reduce the risk of SIDS, but the pacifier should not be forced if the infant doesn't want it. Understanding SIDS is an ongoing area of research as scientists and doctors work to identify causes and develop further preventive measures. Wheezing in children can be a symptom of various diseases, ranging from common and relatively benign conditions to more serious illnesses. Here's a list of diseases and conditions that may present with wheezing in children. 1. Asthma, a chronic inflammatory disorder of the airways characterized by reversible airflow obstruction, hyperresponsiveness, and wheezing. 2. Bronchiolitis, a common lung infection in young children and infants, often caused by the respiratory syncytial virus, RSV, leading to inflammation and congestion in the small airways, bronchioles. 3. Foreign body aspiration. Inhalation of objects, e.g. small toys, food particles, into the airways can cause wheezing, typically unilateral. 4. Viral respiratory infections. Common colds, influenza, and other viral infections can cause wheezing due to inflammation of the airways. 5. Allergic rhinitis. Inflammation of the nasal passages due to an allergic reaction, often associated with asthma, can cause wheezing. 6. Gastroesophageal reflux disease, GERD. Acid reflux can lead to wheezing by irritating the airway or through microaspiration. 7. Cystic fibrosis, a genetic disorder that affects the lungs and digestive system, characterized by thick, sticky mucus that can obstruct the airways. 8. Bronchopulmonary dysplasia, BPD, a chronic lung condition often seen in premature infants who have required mechanical ventilation, characterized by inflammation and scarring in the lungs. 9. Tracheomalacia and bronchomalacia, conditions where the airway walls, trachea or bronchi, are weak and collapse easily, leading to airflow obstruction and wheezing. 10. Heart failure, rare in children but can cause wheezing due to pulmonary edema, fluid buildup in the lungs. 11. Pneumonia, lung infection that can lead to wheezing, especially if the lower airways are involved. 12. Anaphylaxis, a severe, life-threatening allergic reaction that can cause wheezing due to airway constriction. 13. Vocal cord dysfunction, inappropriate closure or narrowing of the vocal cords, leading to wheezing, often mistaken for asthma. 14. Sinusitis, inflammation of the sinuses that can lead to postnasal drip, cough, and sometimes wheezing. 15. Parasitic infections. Certain parasitic infections like ascariasis can cause wheezing due to the migration of larvae through the lungs. The underlying cause of wheezing can often be determined based on the child's age, associated symptoms, and medical history. Diagnosis may require a combination of clinical evaluation, imaging studies, pulmonary function tests, and sometimes bronchoscopy. Treatment depends on the underlying condition causing the wheezing. Cardiac arrhythmias in children can present with a range of symptoms, from being completely asymptomatic to life-threatening situations. The presentation can vary widely depending on the type of arrhythmia, its severity, frequency, and the underlying heart condition, if present. Here are some common symptoms associated with cardiac arrhythmias in children. 1. Palpitations. A sensation of the heart beating too fast, too hard, or irregularly. Children old enough to articulate might complain about their heart racing or skipping beats. Mark 2. Dizziness or lightheadedness. Feelings of unsteadiness or faintness can occur, especially with arrhythmias that significantly affect cardiac output. 3. Syncope, fainting. Episodes of fainting or near fainting may result from decreased blood flow to the brain during significant arrhythmias. 4. Fatigue. General tiredness or weakness, which may be more noticeable during or after physical activity due to the heart's decreased efficiency in pumping blood. 5. Shortness of breath. Difficulty breathing or breathlessness, particularly during exertion, but can also occur at rest in more severe cases. 6. Chest pain or discomfort. While less common in children than in adults, some arrhythmias can cause chest pain or a feeling of pressure in the chest. 7. Poor feeding in infants. Difficulty feeding or tiring easily during feeds can be a sign of arrhythmias in infants, as they may not be able to articulate other symptoms. 8. Exercise intolerance. Reduced ability to engage in physical activity or play, often due to fatigue, breathlessness, or palpitations. 9. Decreased level of consciousness. In severe cases, especially with life-threatening arrhythmias like ventricular tachycardia, children may experience decreased alertness or responsiveness. 10. Cyanosis, a bluish tint to the skin, lips, and nail beds, indicating reduced oxygen levels, can occur in severe cases where the arrhythmia significantly impairs cardiac output. 11. Heart failure symptoms. In chronic cases or arrhythmias leading to heart failure, symptoms might include swelling of the feet, ankles, legs, or abdomen, and weight gain due to fluid retention. It's important to note that not all arrhythmias cause symptoms, and some might be discovered incidentally during a routine examination or an ECG, electrocardiogram, for an unrelated reason. If a child exhibits any of these symptoms, especially if they recur or are severe, it's crucial to seek medical evaluation to determine the cause and appropriate management. Feeding and nutrition are crucial aspects of infant care, ensuring proper growth, development, and health. The nutritional needs of infants change rapidly during the first year of life, transitioning from exclusive milk feeding to the introduction of solid foods. Here's a detailed discussion on the topic. Breastfeeding. Exclusive breastfeeding for the first 6 months. The American Academy of Pediatrics, AAP, and the World Health Organization, WHO, recommend exclusive breastfeeding for the first 6 months. Breast milk provides ideal nutrition and has antibodies that help protect against many common childhood illnesses. Benefits. Breast milk is easily digestible and contains the perfect balance of nutrients. It's also associated with reduced risks of asthma, obesity, type 1 diabetes, and sudden infant death syndrome, SIDS. Continuation with complementary foods. After 6 months, breastfeeding should continue alongside the introduction of solid foods until at least 12 months of age and beyond, for as long as mutually desired by the mother and child. Formula feeding. An alternative or supplement. When breastfeeding isn't possible or needs to be supplemented, infant formulas are a healthy alternative. Formulas aim to closely mimic breast milk and are designed to provide all the necessary nutrients. Types of formula. There are various types of formula available, including cow's milk-based, soy-based, and hypoallergenic formulas to suit different dietary needs and allergies. Introduction of solid foods. Timing. Solid foods should be introduced around 6 months of age when the infant shows signs of readiness, such as being able to sit up with support and showing interest in foods. First foods. Single grain cereals like iron-fortified rice cereal, pureed fruits, vegetables, and meats can be introduced one at a time to monitor for any allergic reactions. Texture and consistency. Start with smooth, single-ingredient purees before moving to thicker textures and combinations of foods as the infant grows and becomes more experienced with eating. Allergenic foods. Foods known to cause allergies, like peanuts, eggs, and fish, should also be introduced early and in small amounts, as current guidelines suggest this may reduce the risk of developing food allergies. Nutritional needs. Iron and zinc. particularly important around 6 months of age, especially for breastfed infants. Iron-fortified cereals or pureed meats can be good first foods to meet these needs. Vitamin D. Breastfed infants may require a vitamin D supplement, as breast milk might not provide enough. Formula-fed infants usually get enough vitamin D from fortified formulas. Feeding practices, responsive feeding. Pay attention to the infant's hunger and fullness cues. Start with small amounts and increase gradually based on the child's appetite. Safety. Avoid choking hazards like whole grapes, nuts, and hard candies. Ensure the child is seated and supervised while eating. Avoiding certain foods. Honey and raw foods. Honey should be avoided until after the first year due to the risk of infant botulism. Similarly, raw or undercooked foods can pose a risk of infection. Hydration. Breast milk or formula is sufficient. For the first 6 months, infants typically don't need additional water. Small amounts of water can be introduced with solid foods after 6 months. Feeding and nutrition in infancy lay the foundation for a child's health, growth, and development. It's important for caregivers to be informed and responsive to the evolving nutritional needs of the infant, ensuring a balanced and safe introduction to a variety of foods after the exclusive milk feeding period. Always consult healthcare providers for personalized advice, especially for managing food allergies or special nutritional needs. Nephrotic syndrome is a kidney disorder that leads to the excretion of too much protein in the urine, proteinuria. This condition can occur in both children and adults, and its hallmark symptoms result from the loss of protein and subsequent imbalances in the body's fluids and other systems. Key symptoms include 1. Edema, swelling. One of the most noticeable signs, particularly around the eyes, periorbital edema, in the ankles and feet, and in more severe cases, the abdomen, ascites. The swelling can worsen throughout the day and may be more pronounced in the lower body due to gravity. 2. Foamy or frothy urine, caused by the excessive protein leaking into the urine. The protein, when agitated, as during urination, can cause the urine to appear foamy. 3. Weight gain. Rapid weight gain due to fluid retention and accumulation in the tissues, not related to an increase in fat or muscle tissue. 4. Fatigue and weakness. Generalized feeling of tiredness and decreased energy levels, partly due to reduced protein in the blood, which can affect overall metabolism and muscle function. 5. Loss of appetite. May occur due to the buildup of fluids in the body or as a general symptom of feeling unwell. 6. Hypoalbuminemia. Low levels of albumin in the blood, a direct result of the protein lost through the kidneys. While not a symptom per se, it's a key diagnostic marker and contributes to edema. Number 7, hyperlipidemia, elevated levels of fats, lipids in the blood, including cholesterol and triglycerides. This can occur as the liver increases lipid production in response to lost protein. 8, increased risk of infections, especially infections that involve the peritoneum, peritonitis, or the respiratory system, due to the loss of immunoglobulins in the urine and altered immune function. 9, vitamin D deficiency, can occur due to the loss of protein-bound vitamin D in the urine, potentially leading to bone weakness or pain. 10. Blood clots, thromboembolism. Increased risk due to changes in the blood's clotting mechanisms, often related to the loss of anticoagulant proteins through the urine. 11. Hypertension. High blood pressure can occur in some cases related to fluid retention and possibly alterations in kidney function that affect blood pressure regulation. Nephrotic syndrome can be a primary kidney disease or secondary to systemic diseases like diabetes, lupus, and infections. The underlying cause of the nephrotic syndrome significantly influences both the presentation and management of these symptoms. Early diagnosis and treatment are crucial to manage symptoms, prevent complications, and treat any underlying conditions contributing to nephrotic syndrome. Acute glomerulonephritis, AGN, is an inflammation of the glomeruli, the tiny filters in the kidneys that help remove excess fluid, electrolytes, and waste from the bloodstream and pass them into the urine. It can occur on its own or as a complication of other diseases, such as infections. Symptoms of AGN can vary in severity and may include 1. Hematuria, blood in the urine, which may make the urine appear pink, red, or cola-colored. This is due to the damaged glomeruli allowing blood cells to leak into the urine. 2. Proteinuria, excess protein in the urine, which may not be noticeable without a urine test, but can lead to foamy urine in some cases. 3. Edema, swelling, particularly in the face, periorbital edema, legs, ankles, and feet due to the kidney's reduced ability to remove water from the body. 4. Hypertension, high blood pressure resulting from the kidney's reduced ability to regulate fluid and salt balance. 5. Oliguria, reduced urine output, as damaged kidneys may produce less urine than normal. 6. Fatigue and weakness, generalized feelings of tiredness and low energy, partly due to the buildup of waste products in the blood that the kidneys fail to filter out. 7. Shortness of breath, due to fluid buildup in the lungs, pulmonary edema, or high blood pressure affecting the cardiovascular system. 8. Fever, may occur, especially if AGN is triggered by an infection. 9. Flank pain, pain in the area around the kidneys, the sides of the body between the upper abdomen and back. 10. Decreased appetite and nausea, often a consequence of the buildup of toxins and wastes in the bloodstream that the kidneys are unable to filter out. The symptoms of AGN can develop suddenly, acute, or gradually, chronic, and they often appear 1 to 2 weeks after an infection in other parts of the body, such as a strep throat or skin infection. It's crucial to seek medical attention if AGN is suspected, as early treatment can help preserve kidney function and prevent complications. Diagnosis typically involves urine tests, blood tests, imaging studies, and sometimes a kidney biopsy to assess the extent of glomerular damage and to guide treatment decisions. Hemolytic uremic syndrome, HUS, is a complex condition that primarily affects the blood and blood vessels, resulting in the destruction of blood cells, a low platelet count, thrombocytopenia, and kidney failure. HUS is most commonly caused by infection with certain strains of Escherichia coli, E. coli, particularly E. coli O157H7. It can also result from other infections, certain medications, or be genetically inherited, leading to atypical HUS. The symptoms of HUS typically develop after the initial symptoms of the gastrointestinal illness, often characterized by severe diarrhea, and can include 1. Bloody diarrhea, often the first symptom, resulting from the initial gastrointestinal infection. 2. Abdominal pain, cramping or severe pain in the abdomen. 3. Vomiting and nausea can accompany the gastrointestinal symptoms. 4. Fever, might be present but is not always a significant feature. 5. Pallor, pale appearance due to anemia caused by the destruction of red blood cells, hemolysis. 6. Fatigue and weakness, resulting from anemia and the overall impact of the illness on the body. 7. Decreased urine output, a sign of kidney involvement and potential failure, which may progress to anuria, complete cessation of urine output. 8. Blood in the urine, hematuria, can occur due to kidney damage. 9. Swelling, edema, especially in the legs, feet, or face, due to kidney dysfunction leading to fluid retention. 10. Petechiae and purpura, small red or purple spots on the skin, resulting from bleeding under the skin due to low platelet counts. 11. Irritability and confusion may occur, especially in severe cases, due to the effects of toxins accumulating in the blood that the kidneys can't filter out. 12. Hypertension, high blood pressure can develop as a result of kidney injury. 13. Seizures or strokes, in severe cases due to the effects of the disease on the brain. HUS is a medical emergency requiring immediate attention. The diagnosis is typically based on the triad of hemolytic anemia, thrombocytopenia, and acute renal impairment, alongside the presenting symptoms and history of a preceding diarrheal illness. Treatment focuses on supportive care, which may include fluid management, blood transfusions, and dialysis to support kidney function. In cases of atypical HUS, specific treatments targeting the complement system, such as eculizumab, may be used. Henoch-Schönlein purpura, HSP, also known as IgA vasculitis, is a small vessel vasculitis that predominantly affects children, characterized by the deposition of IgA immune complexes in the skin, joints, gastrointestinal tract, and kidneys. The condition usually follows an upper respiratory tract infection and presents with a distinctive set of symptoms, including 1. Rash. The most recognizable feature is a purpuric rash, which is reddish-purple spots that do not blanch under pressure. The rash typically appears on the buttocks, legs, and sometimes the arms and face. 2. Joint pain and swelling. Arthralgia or arthritis, especially in the knees and ankles, can occur, leading to pain and swelling in the affected joints. Joint symptoms are usually transient and non-erosive, meaning they don't cause long-term damage to the joint. 3. Abdominal pain. Gastrointestinal involvement can lead to abdominal pain, which can be colicky in nature and is often accompanied by vomiting or nausea. In more severe cases, there can be gastrointestinal bleeding and intussusception, a serious condition where part of the intestine slides into an adjacent part of the intestine. 4. Renal involvement. Hematuria, blood in the urine, and proteinuria, protein in the urine, can indicate renal involvement, which is a more serious manifestation of HSP. The extent of kidney involvement varies, from mild and transient changes to more severe nephritis. 5. Fever. Some patients may have a fever, although it is not typically high grade. 6. Edema. Swelling around the joints or in the face, hands, and feet can occur, particularly in more severe cases. 7. Scrotal swelling. In boys, HSP can cause swelling and pain in the scrotum, which can sometimes be mistaken for testicular torsion or other acute scrotal conditions. 8. Headache and neurological symptoms. Rarely, HSP can affect the central nervous system, leading to symptoms such as headaches, seizures, or behavioral changes. It's important to note that not all symptoms need to be present for a diagnosis of HSP, and the severity of symptoms can vary widely among individuals. The rash and joint symptoms are usually the most prominent and often the first to appear. The course of HSP is usually self-limiting, with symptoms typically resolving within a month, though they can recur in about a third of cases. Kidney involvement requires careful monitoring, as it can lead to more serious long-term issues in a small percentage of cases. Treatment is mainly supportive, focusing on symptom relief, and may include NSAIDs for joint pain and corticosteroids for more severe cases, especially with significant abdominal or kidney involvement. Sideropenic anemia, more commonly known as iron deficiency anemia, is the most common type of anemia in children and is characterized by a deficiency in iron, which is essential for the production of hemoglobin in red blood cells. Hemoglobin carries oxygen from the lungs to the rest of the body, and without enough iron, the body can't produce sufficient hemoglobin, leading to reduced oxygen delivery to tissues. Symptoms of iron deficiency anemia in children can include 1. Fatigue and weakness. Children may appear less energetic or tire easily during play due to decreased oxygen supply to muscles. 2. Pallor. Notable paleness, especially noticeable in the face, lips, lower inner eyelids, and nails, reflecting reduced hemoglobin levels. 3. Irritability. Children may be more fussy or irritable than usual due to the discomfort or fatigue associated with anemia. 4. Decreased appetite. Iron deficiency can lead to a reduced desire to eat, exacerbating the nutritional deficiency. 5. Poor concentration and cognitive delays. Iron is crucial for cognitive development, so deficiency may impair concentration and learning, and in severe cases, contribute to developmental delays. 6. Pica, a craving for non-food items like dirt, chalk, or ice, which is a peculiar but well-documented symptom of iron deficiency. 7. Increased susceptibility to infections. Iron plays a role in immune function, so deficiency may lead to an increased frequency of infections. 8. Shortness of breath or rapid breathing occurs especially during exercise due to the reduced oxygen carrying capacity of the blood. 9. Cold hands and feet. Reduced oxygen delivery can lead to feelings of coldness, particularly in the extremities. 10. Headaches and dizziness. Possible symptoms, especially in more severe cases, due to reduced oxygen supply to the brain. 11. Growth retardation. Chronic iron deficiency can impair growth and development in children. 12. Brittle or spoon-shaped nails, koilonychia. In severe cases, children might present with brittle nails that may become concave or spoon-shaped. 13. Tachycardia or heart murmur. The heart may beat faster than normal or present a murmur as it tries to pump more blood to compensate for the reduced oxygen carrying capacity. It's crucial to identify and treat iron deficiency anemia early to prevent potential long-term developmental and cognitive impairments. Treatment typically involves dietary changes to include more iron-rich foods and, if necessary, iron supplements as prescribed by a healthcare professional. Regular monitoring of iron levels and hemoglobin is also essential to ensure the effectiveness of the treatment and to prevent recurrence. Hemolytic anemia occurs when red blood cells are destroyed faster than the bone marrow can produce them. This condition can be inherited, such as in hereditary spherocytosis or sickle cell anemia, or acquired due to infections, autoimmune diseases, certain medications, or exposure to toxic substances. Symptoms of hemolytic anemia in children can vary depending on the cause, severity, and whether the onset is acute or chronic, but generally include 1. Pallor, pale skin, lips, and nail beds, indicating reduced hemoglobin levels and decreased oxygen carrying capacity. 2. Fatigue and weakness. Due to lower oxygen delivery to the body's tissues, children may tire easily and seem less energetic or lethargic. 3. Jaundice, yellowing of the skin and the whites of the eyes, sclera, due to an increase in bilirubin, a byproduct of red blood cell breakdown. 4. Dark urine. Urine may appear dark or tea-colored due to the presence of bilirubin or hemoglobin. 5. Splenomegaly, enlarged spleen. The spleen may enlarge due to its role in filtering and breaking down the excess red blood cells. 6. Shortness of breath. Children may experience difficulty breathing or increased respiratory rate due to reduced oxygen levels in the blood. 7. Rapid heart rate, tachycardia. The heart may beat faster in an effort to deliver enough oxygen to the body's tissues. 8. Dizziness or lightheadedness. May occur due to reduced oxygen supply to the brain. 9. Headache, a common symptom also related to decreased oxygen delivery to the brain. 10. Chills and fever, particularly if the hemolytic anemia is due to an infection or autoimmune response. 11. Abdominal pain can be caused by an enlarged spleen or liver, or in the case of sickle cell anemia, by vaso-occlusive crises. 12. Leg ulcers, more common in specific types of hemolytic anemia, such as sickle cell anemia. 13. Gallstones may develop due to the increased breakdown of red blood cells, leading to an excess of bilirubin. In children, the symptoms of hemolytic anemia might also affect growth and development, and in severe cases, lead to heart failure or other life-threatening complications. It's important to identify and treat the underlying cause of hemolytic anemia. Treatment options may include medications, blood transfusions, plasmapheresis, in cases of immune-mediated hemolytic anemia, or in some cases, surgery. Acute immune thrombocytopenia, ITP, formerly known as idiopathic thrombocytopenic purpura, is an autoimmune disorder characterized by a low platelet count, thrombocytopenia, without a clear cause. The body's immune system mistakenly attacks and destroys its own platelets, which are essential for blood clotting. This condition is most commonly seen in children and often follows a viral infection. Symptoms can vary from mild to severe and include 1. Small, round spots that appear on the skin as a result of bleeding under the skin. These are often red, purple, or brown and are most commonly seen on the lower legs, feet, and occasionally on the trunk or arms. 2. Bruising, ecchymosis. Children may bruise easily and excessively, even from minor bumps or injuries due to the decreased ability of the blood to clot. 3. Purpura, larger areas of bleeding under the skin that may look like large bruises or patches. 4. Nosebleeds, epistaxis. Frequent or prolonged nosebleeds are common due to the reduced platelet count. 5. Bleeding gums. Bleeding from the gums, especially during brushing teeth, may be a sign of ITP. 6. Blood in the urine or stool. Hematuria, blood in the urine, or melena, black, tarry stools, or hematochezia, fresh blood in stools, indicating internal bleeding. 7. Menorrhagia. In adolescent girls, heavier than normal menstrual bleeding can be a symptom of ITP. 8. Fatigue and weakness. These nonspecific symptoms can result from the body's increased efforts to compensate for the loss of platelets. 9. Prolonged bleeding from cuts or injuries. Wounds may take longer than usual to stop bleeding. 10. Internal bleeding. Although less common, severe ITP can lead to bleeding in the brain or other internal organs, which can be life-threatening and would present as severe headache, vomiting, confusion, or changes in behavior. It's important to note that many children with ITP may not exhibit any symptoms, and the condition is often discovered incidentally during a routine blood test. Acute ITP in children is usually self-limiting, with platelet counts returning to normal without specific treatment within 6 months. However, monitoring is essential to manage bleeding risks, and treatments such as corticosteroids, intravenous immunoglobulin, IVIG, or anti-D-immunoglobulin may be used in more severe cases to raise the platelet count quickly. In rare cases where ITP becomes chronic or severe, other treatments, including splenectomy or newer agents like thrombopoietin receptor agonists, may be considered. Hemophilia is a genetic disorder characterized by the inability of the blood to clot properly due to a deficiency or absence of certain clotting factors. It primarily affects males, with females typically being carriers of the condition. Hemophilia A, deficiency of factor VIII, is the most common type, followed by hemophilia B, deficiency of factor IX. The severity of symptoms can vary widely, depending on the level of clotting factor activity. Common symptoms in children with hemophilia include 1. Excessive bleeding. Prolonged bleeding from cuts or injuries is a hallmark symptom, as the blood does not clot as it should. 2. Spontaneous bleeding. Bleeding can occur without any apparent cause, affecting joints, muscles, and internal organs. 3. Joint bleeding, hemarthrosis. Frequent bleeding into joints, especially knees, elbows, and ankles, leading to pain, swelling, and stiffness. Repeated episodes can result in joint damage and arthritis over time. 4. Easy bruising. Children may bruise easily and excessively, even from minor bumps or injuries. 5. Bleeding in muscles, hematomas. Bleeding within muscles can cause swelling, pain, and limited movement. 6. Bleeding in the mouth and gums. Prolonged bleeding from minor cuts or after dental work, and spontaneous bleeding from gums. 7. Nosebleeds. Frequent or prolonged nosebleeds are common and may be difficult to control. 8. Blood in the urine or stool. Hematuria, blood in the urine, or blood in stools may indicate bleeding in the kidneys or gastrointestinal tract. 9. Cerebral hemorrhage. Bleeding in the brain is a severe complication that can occur from a head injury or spontaneously. Symptoms can include severe headache, vomiting, neck stiffness, sudden weakness, vision changes, and altered consciousness. 10. Prolonged bleeding after circumcision. In newborns with hemophilia, excessive bleeding after circumcision can be an early sign of the disorder. 11. Excessive bleeding after vaccinations. Prolonged bleeding at the injection site following routine vaccinations. The severity and frequency of bleeding episodes in hemophilia can vary widely. In severe cases, spontaneous bleeding or bleeding from minor injuries can be frequent and difficult to control, while in mild cases, significant bleeding may only occur with surgery or major trauma. Early diagnosis and treatment are crucial to manage symptoms and prevent complications. Treatment typically involves replacing the missing clotting factor through regular infusions, and in some cases, prophylactic, preventive treatment to reduce the frequency of bleeding episodes. Newer therapies that help stimulate the production of the clotting factor or mimic its action are also available for some patients. Brain tumors in children can present with various symptoms, which often depend on the tumor's size, type, and location, as well as the child's age and development. Symptoms can be related to increased intracranial pressure, ICP, caused by the tumor itself or associated swelling, direct effects of the tumor on brain function, or a combination of these factors. Common symptoms include 1. Headaches, often worse in the morning or worsen with activity. They may be accompanied by nausea or vomiting. 2. Nausea and vomiting, especially vomiting that occurs in the morning or without nausea, can be a sign of increased ICP. 3. Seizures. New onset seizures or convulsions can be a sign of a brain tumor in children without a history of seizure disorders. 4. Vision changes. Blurred vision, double vision, or loss of vision, particularly if these symptoms are progressive. 5. Behavioral or personality changes. Changes in mood, personality, or ability to concentrate. Young children may become more irritable or less interactive. 6. Motor skills decline. Difficulty with balance and coordination, weakness in one part of the body, or a change in gait. 7. Increased head size in infants. In infants, a rapidly increasing head circumference could indicate a brain tumor. 8. Fatigue and lethargy. Unexplained tiredness or decreased energy levels. 9. Delayed puberty or abnormal growth. Brain tumors can affect hormone regulation, leading to delayed or precocious puberty or abnormal growth patterns. 10. Abnormal eye movements, such as strabismus, crossed eyes, or nystagmus, rapid eye movements. 11. Tilting of the head or neck pain. A new tilt of the head or complaints of neck pain, especially in young children, can be a symptom. 12. Difficulty with speech or comprehension. Problems with understanding language, speaking, reading, or writing. 13. Changes in sensation. Numbness or tingling in the limbs or on one side of the body. It's important to note that many of these symptoms can also be caused by more common and less serious conditions. However, if these symptoms are persistent, progressive, or multiple symptoms are present, it's crucial to consult a healthcare provider for a thorough evaluation. Diagnosis often involves neurological examination, followed by imaging studies such as MRI or CT scans. Early detection and treatment of brain tumors in children can significantly affect the outcome and may include a combination of surgery, radiation therapy, and chemotherapy, tailored to the individual child's situation. Hodgkin's lymphoma, previously known as Hodgkin's disease, is a type of lymphoma characterized by the presence of Reed-Sternberg cells in the lymph nodes. It can occur in both adults and children, but the symptoms and presentation can vary slightly with age. In children, symptoms of Hodgkin's lymphoma may include 1. Painless swelling of lymph nodes, the most common symptom, often noticed in the neck, armpits, or groin. The lymph node enlargement is usually painless, although some children might experience discomfort or tenderness with pressure. 2. Fever. Unexplained fevers that come and go, often without any other signs of infection. 3. Night sweats. Drenching sweats that may require changing bed linens or night clothes, not related to an overheated sleeping environment. 4. Unexplained weight loss. Significant weight loss without changes in diet or exercise habits. 5. Persistent fatigue, feeling tired or exhausted all the time, not relieved by rest or sleep. 6. Itchy skin, generalized itching without an apparent rash or allergic cause. 7. Coughing or breathlessness. If the lymph nodes in the chest are affected, they may press against the windpipe or lungs, leading to coughing or shortness of breath. 8. Enlarged spleen or liver. In some cases, the disease can cause the spleen or liver to enlarge, which might be felt as fullness in the abdomen or detected during a physical examination. 9. Pain in lymph nodes after alcohol consumption, a rare symptom where the affected lymph nodes may hurt after drinking alcohol. 10. Loss of appetite. Children may show a decreased interest in eating, leading to weight loss. 11. Increased susceptibility to infections. Due to the compromised immune system, children may experience more frequent or severe infections. 12. Anemia. Symptoms such as paleness, increased heart rate, and tiredness may occur if Hodgkin's lymphoma affects the body's ability to produce enough red blood cells. It's important to note that many of these symptoms can be caused by more common, less serious conditions, such as infections. However, if these symptoms are persistent, progressive, or unusual for the child, it's essential to seek medical evaluation. A biopsy of the enlarged lymph node is typically required to confirm the diagnosis of Hodgkin's lymphoma. Treatment usually involves chemotherapy and, in some cases, radiation therapy, with the approach tailored to the child's specific situation and the stage of the disease. The prognosis for children with Hodgkin's lymphoma is generally very good, with high cure rates, especially when the disease is detected early and treated appropriately. Hypoglycemia, a condition characterized by an abnormally low level of glucose, sugar, in the blood, can cause a range of symptoms that may vary among individuals. These symptoms can be divided into two main categories: adrenergic, or neurogenic symptoms, which are related to the body's response to low blood sugar, and neuroglycopenic symptoms, which occur due to a lack of glucose supply to the brain. Common symptoms of hypoglycemia include adrenergic, neurogenic symptoms, a common early sign, often described as trembling or feeling jittery, sweating, cold sweats, even in the absence of heat or physical exertion, palpitations, feeling of a fast, strong, or irregular heartbeat, anxiety or nervousness, feelings of unease, anxiety, or panic, hunger, intense or sudden hunger pangs, neuroglycopenic symptoms, confusion or difficulty concentrating, trouble focusing, thinking clearly, or making decisions, weakness or fatigue, generalized tiredness or a sudden loss of energy, dizziness or lightheadedness, feeling faint or dizzy, especially when standing up, blurred vision, temporary vision changes such as blurriness or double vision, headache, mild to severe headaches. Other symptoms, mood changes, irritability, moodiness, or even sudden changes in behavior, such as crying for no apparent reason. Seizures or convulsions, in severe cases, particularly if blood sugar levels drop very low. Loss of consciousness or coma, in extreme cases where hypoglycemia is severe and untreated. Symptoms in infants and young children. In infants and young children, especially those unable to communicate their symptoms effectively, signs of hypoglycemia might include persistent crying, irritability, sleepiness, and in severe cases, seizures. Hypoglycemia can occur for various reasons, including prolonged fasting, certain medications, most commonly in people with diabetes who use insulin or certain types of diabetes pills, excessive alcohol consumption without eating, and less commonly, due to certain medical conditions. It's important to recognize and treat hypoglycemia promptly, as severe or prolonged low blood sugar can lead to serious complications. Treatment typically involves consuming fast-acting carbohydrates, such as glucose tablets, fruit juice, or regular soda, to quickly raise blood sugar levels, followed by a more substantial food item containing complex carbohydrates and protein to help stabilize blood sugar. Diabetic ketoacidosis, DKA, is a serious and potentially life-threatening complication of diabetes, more common in type 1 diabetes, but can also occur in type 2 diabetes under certain conditions. It results from a severe shortage of insulin, leading to high blood sugar levels and the accumulation of ketones in the blood and urine. Ketones are acidic chemicals produced when the body starts breaking down fat for energy due to the lack of available glucose. Symptoms of DKA can develop quickly, often within 24 hours, and include 1. Excessive thirst and frequent urination. High blood sugar levels lead to increased urine production, which results in dehydration and compensatory thirst. 2. Nausea and vomiting. The buildup of ketones in the body can cause nausea and vomiting, which can further contribute to dehydration. 3. Abdominal pain. Many patients with DKA experience abdominal pain, which can be severe. 4. Fatigue and weakness. Lack of glucose utilization by the body's cells for energy leads to feelings of tiredness and weakness. 5. Confusion or altered mental state. Severe electrolyte imbalances and the effects of ketones on the brain can lead to confusion, drowsiness, and difficulty concentrating. In extreme cases, it can progress to coma. 6. Fruity scented breath. The presence of ketones in the blood can cause the breath to have a fruity odor, often described as similar to nail polish remover. 7. Rapid breathing or Kussmaul respiration. A deep, labored breathing pattern as the body attempts to correct the blood's acidity. 8. Dehydration. Signs of dehydration include dry mouth and skin, sunken eyes, and decreased skin turgor. 9. Rapid heartbeat. Dehydration and electrolyte imbalances can lead to tachycardia, rapid heartbeat. 10. Low blood pressure. Severe dehydration can cause hypotension, low blood pressure. 11. High blood glucose levels. Blood glucose levels are often significantly elevated in DKA. 12. Presence of ketones in urine. Ketones will be present in the urine and can be detected with a urine test strip. DKA requires immediate medical attention and is treated in a hospital setting. Treatment involves the administration of insulin to reduce blood glucose levels, fluids to rehydrate the body, and electrolytes, such as potassium, to restore the body's balance. Early recognition and treatment of the signs and symptoms of DKA are crucial to prevent severe complications and mortality. In a 10-year-old child with a right-sided pneumothorax, the physical examination might reveal several abnormalities indicating the presence of air in the pleural space, which can lead to partial or complete lung collapse on the affected side. Key findings may include 1. Asymmetrical chest expansion, reduced or absent movement of the right chest wall during inspiration due to the inability of the collapsed lung to expand properly. 2. Decreased or absent breath sounds. Upon auscultation with a stethoscope, breath sounds may be diminished or entirely absent over the right hemithorax, especially in the area of the pneumothorax. 3. Hyperresonance on percussion. The right side of the chest may produce a hollow, drum-like sound when tapped percussed, indicating the presence of air in the pleural space. 4. Tracheal deviation. In cases of significant or tension pneumothorax, the trachea may be shifted away from the affected side, to the left in this case, due to the pressure from the air in the pleural space. 5. Tachypnea. Increased respiratory rate as the child attempts to compensate for the reduced lung function and maintain adequate oxygenation. 6. Cyanosis. Bluish discoloration of the lips, fingernails, or skin indicating decreased oxygenation may be present in severe cases. 7. Distended neck veins. In tension pneumothorax, increased intrathoracic pressure can impede venous return to the heart, leading to jugular venous distension. 8. Chest pain. The child may report sharp or stabbing chest pain on the affected side, which may worsen with deep breaths, pleuritic chest pain. 9. Tachycardia. An increased heart rate as a response to hypoxemia and stress. 10. Subcutaneous emphysema. In some cases, air from the pneumothorax can escape into the subcutaneous tissue, leading to a crackling sensation upon palpation of the skin, particularly around the chest, neck, and shoulders. It's important to note that the clinical presentation can vary based on the size and cause of the pneumothorax. A small pneumothorax might present with subtle or even no physical findings, while a large or tension pneumothorax can cause significant respiratory distress and hemodynamic instability, requiring immediate intervention. Diagnosis is typically confirmed by chest X-ray or ultrasound, and treatment depends on the size and severity of the pneumothorax, ranging from observation and oxygen supplementation to needle decompression or chest tube placement in more severe cases. Whooping cough, also known as pertussis, is a highly contagious respiratory infection caused by the bacterium Bordetella pertussis. It's known for its severe coughing fits, followed by a whooping sound when the person breathes in. The disease can affect people of all ages, but is most severe in infants and young children. The course of whooping cough can be divided into 3 stages. 1. Catarrhal stage, 1 to 2 weeks. Mild fever. Low-grade fever is common. Runny nose, nasal congestion, or rhinorrhea. Mild cough. Initially, the cough is mild and can be mistaken for a common cold. Sneezing. Frequent sneezing episodes. Tiredness, general malaise, and fatigue. 2. Paroxysmal stage, 1 to 6 weeks or longer. Severe coughing fits and severity. Intense bouts of coughing that can last for several minutes and are often uncontrollable. Whooping sound. A high-pitched whoop sound may be heard when the child gasps for air after a coughing fit. Note that this classic whooping sound may not be present in all cases, especially in very young infants. Post-tussive vomiting. Vomiting following coughing fits due to the severity of the cough. Apnea. In infants, coughing may be minimal or absent, but apnea, pauses in breathing, can occur. Facial cyanosis. The face may turn red or purple during coughing fits, and in severe cases, cyanosis, bluish tint to the skin due to lack of oxygen, can occur. Exhaustion. The severe coughing fits can leave the child extremely tired. H3. Convalescent stage, weeks to months. Gradual recovery. The severity of coughing fits decreases over time. Persistent cough. A cough may persist for several weeks or even months, gradually becoming less severe. Complications of whooping cough can be severe, especially in infants, and may include pneumonia, seizures, brain damage, and, in rare cases, death. Early detection and treatment with antibiotics can help reduce the severity of symptoms and prevent the spread of the disease. Vaccination is the most effective way to prevent whooping cough, with vaccines available for infants, children, and adults. Due to waning immunity, booster shots are recommended for older children and adults, especially those in close contact with young infants. Epiglottitis and croup are both respiratory conditions that affect children and can lead to significant airway obstruction, but they differ in their causes, affected age groups, symptoms, and urgency of treatment. Here's a detailed differentiation between the two. Epiglottitis. Cause. Typically caused by a bacterial infection, historically Haemophilus influenzae type B, Hib before the advent of Hib vaccination. Now more commonly associated with other bacteria. Age group. Previously common in children between 2 to 5 years, but now more often seen in older children and adults due to widespread Hib vaccination. Onset. Acute and rapid onset, developing over hours. Symptoms. High fever. Severe sore throat, difficulty swallowing, drooling due to difficulty swallowing saliva, muffled or hoarse voice, significant respiratory distress, stridor, a high-pitched wheezing sound, and rapid progression to severe breathing difficulty. Sitting in a tripod position, leaning forward with hands on knees to ease breathing. Vaccination, incidence greatly reduced by Hib vaccine. Treatment, medical emergency requiring immediate attention. Treatment typically involves securing the airway, antibiotics, and corticosteroids. Croup laryngotracheobronchitis. Cause. Most commonly caused by viral infections, particularly the parainfluenza virus. Atypically affects younger children aged 6 months to 3 years. Onset. More gradual onset, often preceded by symptoms of a common cold. Symptoms. Barking cough, often described as resembling the bark of a seal. Stridor, more prominent when the child is upset or crying. Low-grade fever. Hoarseness and mild respiratory distress. Symptoms often worsen at night. Vaccination. No specific vaccine for croup, as it is usually caused by common viruses. Treatment. Often managed at home with cool mist humidifiers, hydration, and comforting. Severe cases may require hospitalization for nebulized epinephrine and corticosteroids to reduce airway inflammation. Key differences in presentation. Voice changes. Muffled voice in epiglottitis versus hoarse voice in croup. Cough, absent or less prominent in epiglottitis, characteristic barking cough in croup. Drooling, more common in epiglottitis due to difficulty swallowing. Posture, tripod positioning in epiglottitis to relieve breathing difficulty. No specific posture in croup. Stridor, present in both, but in croup, it's usually more prominent with agitation and less severe than in epiglottitis. It's crucial to recognize the signs of epiglottitis as a medical emergency requiring immediate hospitalization. While croup can often be managed with supportive care, severe cases may also need medical attention. Cystic fibrosis, CF, is a genetic disorder that affects the exocrine glands, leading to the production of abnormally thick and sticky mucus. This mucus can cause blockages in various organ systems, particularly the lungs and digestive system. The symptoms and signs of cystic fibrosis can vary widely among individuals and may develop or change over time. Common manifestations include respiratory symptoms, persistent cough, often productive, bringing up thick mucus, recurrent chest infections, frequent bouts of bronchitis or pneumonia due to mucus obstructing the airways and trapping bacteria, wheezing and shortness of breath, difficulty breathing or wheezing, especially with physical activity, nasal congestion and sinusitis, chronic stuffiness and sinus infections due to mucus buildup, digestive symptoms, poor growth and weight gain, difficulty absorbing nutrients leading to malnutrition and failure to thrive, steatorrhea, bulky, greasy, and foul-smelling stools due to malabsorption of fats, intestinal blockage, particularly in newborns, meconium ileus, blockage of the intestine by thick meconium, can be a first sign of CF. Rectal prolapse occurs in some children due to the strain of passing thick stools. Distal intestinal obstruction syndrome, DIOS, a condition similar to a bowel obstruction with symptoms like abdominal pain, nausea, and vomiting. Other symptoms and signs. Salty tasting skin. Parents may notice that their child's skin tastes salty when they kiss them. Clubbing, enlargement or rounding of the fingertips and toes due to chronic low oxygen levels in the blood. Delayed puberty, in some adolescents due to nutritional deficiencies. Infertility, particularly in males due to obstructed vas deferens. Females may also have reduced fertility due to thick cervical mucus. Additional complications, cystic fibrosis-related diabetes, CFRD, a unique type of diabetes associated with CF arising from insulin insufficiency due to pancreatic damage. Liver disease. Some individuals develop liver problems, including cirrhosis due to the buildup of thick bile. Osteoporosis, increased risk due to malabsorption of vitamin D and calcium, as well as other factors. The severity and combination of symptoms can vary significantly among individuals with CF, and not all symptoms are present in every case. The diagnosis of cystic fibrosis is often confirmed through newborn screening, sweat chloride tests, and genetic testing. Management of CF is complex and typically involves a multidisciplinary approach to address respiratory and digestive complications, nutritional needs, and other aspects of care, with the goal of improving quality of life and lifespan. Anorexia nervosa is a serious eating disorder characterized by a self-imposed starvation due to an intense fear of gaining weight and a distorted body image. In a 15-year-old girl with a significantly low body mass index, BMI of 10, severe malnutrition and the psychological aspects of the disorder can lead to multiple physical abnormalities. During a physical examination, the following abnormalities might be noted. 1. Extreme weight loss. Significantly low body weight for age and height with visible signs of malnutrition and muscle wasting. 2. Vital signs. Bradycardia, a slow heart rate, often below 60 beats per minute. Hypotension, low blood pressure, especially noticeable when standing up. Orthostatic hypotension. Hypothermia, lowered body temperature due to lack of insulating body fat. 3. Skin changes. Dry, thin, and pale skin due to malnutrition. Lanugo, fine, downy hair growth on the face and body, a physiological response to maintain body warmth due to loss of insulating body fat. Acrocyanosis, bluish discoloration of the hands and feet due to poor circulation. Russell's sign, calluses or abrasions on the knuckles from self-induced vomiting. 4. Hair and nails, brittle hair and nails due to malnutrition. Alopecia, hair loss, which can be noticeable. 5. Cardiovascular, murmurs, may be detected due to altered cardiac function. Peripheral edema, swelling of the lower extremities, which can be a sign of hypoalbuminemia. 6. Gastrointestinal, abdominal tenderness may be present, delayed gastric emptying, leading to bloating and early satiety. 7. Musculoskeletal, muscle wasting, loss of muscle mass due to malnutrition. Osteopenia, osteoporosis, increased risk of bone loss and fractures. 8. Neurological, cognitive impairment, difficulty concentrating or thinking clearly. Peripheral neuropathy may manifest as tingling or numbness in extremities. 9. Endocrine, amenorrhea, absence of menstruation due to hormonal imbalances. Growth delay, In adolescence, chronic malnutrition can lead to delayed growth or puberty. 10. Psychiatric. Anxious or depressive features may be observed during the interaction. Obsessive behaviors related to food and weight. It's crucial to approach the management of anorexia nervosa with a multidisciplinary team, including medical stabilization, nutritional rehabilitation, and psychological interventions. Given the severity indicated by a BMI of 10, hospitalization is often required to address the acute medical risks associated with such profound malnutrition.